Good morning.
Good morning.
Welcome to the Sunday morning section. We have a really exciting bunch of talks today, starting with Theo, aka Ted Habarth-Morales, working with EJ Caterson at DuPont, who's going to give us a historical talk. And given that the first session this morning, the first talk this morning is a historical talk, and we're really excited that Dr. Perry will be present with us on Zoom for the first talk this afternoon to zoom in a little bit and talk about the history of the group. We are delighted that Theo, who has also been our tech guy because he's so able, is able to teach us about history. Let her rip.
So I'm Theo. I'm a medical student at Thomas Jefferson, doing a research fellowship with Dr. Caterson this year down at Nemours. And I'm going to be talking a little bit about medicine's victories off the battlefield. So the American Civil War gave us anesthesia. World War I gave us transfusions and the ambulance corps, which then laid the foundations for the EMS system.
You just muted yourself accidentally somehow, or Jamie muted you.
Yeah, I'm not muting it. I think it's doing it automatically. All right, well, it's unmuted now. So the Korean War, we started seeing widespread use of medevac and helicopters to evacuate casualties. And then, of course, the MASHs and forward surgical teams arose out of a necessity or recognition that we needed to have surgical intervention closer to the battlefield. Vietnam War, we started seeing frozen blood products, which were used widespread, that allowed blood banks to retain their blood products for a lot longer than the couple of days that we were seeing in World War II. And there was a big effort to focus on burn care. And we saw a lot of advances in burn care during the Vietnam War. And then most recently, of course, the global war on terror, we saw widespread use of tourniquets and fibrin bandages, which have now eventually permutated into the civilian EMS and pre-hospital sector. So that's a great example recently. So the only problem with this narrative, of course, is that it's not all encompassing, and we're missing a couple of big advances that have arisen out of some natural disasters and other civilian mass casualty incidences. So I posit that we should alter the quote to say that disaster is the only proper school of the surgeon. So on December 28th, 1908, in Sicily and Calabria, Italy, there was a big earthquake called the Messina earthquake, named after the biggest town there that was affected. So at about 5:20 in the morning, a 7.1 scale earthquake hit right between Sicily and the Italian coast here. So 75,000 citizens of the town were instantly killed in the 30 seconds that the ground was quaking. 91% of the structures in the town were destroyed. So the town was basically leveled. Along with that, all the military and civilian hospitals that were in the town were also destroyed, and most of the staff also killed. To make matters worse, railroads were not operable, and neither were telegraph lines. So it actually wasn't until midnight that night that some naval ships out of the detachment near the town were able to navigate their way up north towards Naples and let the prime minister know at the time. And that's kind of when everyone found out, and aid started coming in within the next few days. So the relief efforts were, it's pretty interesting. This was right before World War I. And, we had ships sent to Italy from the United States, Russia, England, France, Germany. There were some German Red Cross detachments that came down on land through the South. And so I'm going to fast forward a little bit here. Dr. Eric Bywaters was a surgeon and had an interest in rheumatology, actually. And he was in the United States right before World War I hit. At the start of World War I, he got called back to England, couldn't serve in the medical corps because of a knee issue, but he worked in one of the military hospitals. And during the Battle of London and the Blitz, he published this paper in the British Medical Journal, which was widely thought of, and to this day even, the first description of crush injury and the pathophysiology and the renal involvement. So in the journal here, or in the article here, he states, along with his other co-author, that a literature review didn't reveal any previous descriptions of crush injury. The only problem was he didn't do a very good literature review, it seems like, because there were actually 3 descriptions of it arising from the Messina earthquake. Now, let's give Dr. Bywaters the benefit of the doubt here. I don't know how easy it was to do literature reviews back in that time, because I complain about doing them, and they're all at the tip of our fingertips here on the internet. And he also had bombs raining down on him from the Germans, so we'll go ahead and forgive that. He actually did a couple of years later, when he was notified of these other pieces of literature, did issue an apology and gave credit to Dr. von Kolmers, who I'm going to talk about now. So Dr. Franz von Kolmers was a German army doctor who was part of one of the Red Cross detachments. He arrived in Messina about a week after the quake and cared for a couple hundred victims of the quake. And he published this paper in 1908 and also gave a talk to the German Congress of Surgery about crush injury and what he observed. Dr. von Kolmers didn't really go into the renal manifestations too much, but 2 surgeons from southern Italy, Dr. Antonio D'Antona and Rocco Caminiti, whose great-grandson is a plastic surgeon out there now, both gave separate accounts from the patients that they cared for. So they were both in Naples. Dr. Caminiti was actually injured in the quake and showed up at the hospital the next morning with a broken leg and was caring for patients there. So these 2 surgeons were the first to detail crush injury, and it's good to give them credit. But anyways, this disaster brought a lot of, even though Dr. Bywaters didn't go back and look at this literature, it was still a worthwhile contribution to what we know today, of course. So next, the Halifax explosion. So a couple years later, on 6 December 1917 in Halifax, Nova Scotia, the largest man-made explosion at that point would happen. So 2 ships were the cause of it. The SS Mont Blanc, which was a French ship which was going from New York to France and stopping in Halifax, and was carrying munitions to the French. So TNT, picric acid, benzol, gun cotton, all things you don't really want to set on fire. Collided with the SS Emo, which was in ballast, wasn't carrying anything, just water, which was on its way to New York. So it was coming out of the harbor on its way to New York and then Belgium. It was part of the Belgian relief effort. So an interesting chain of events here. The Emo was actually supposed to leave the night prior, but it was stuck waiting for some coal. So it had to stay inside the harbor that night. And then the SS Mont Blanc was coming into the harbor. It arrived too late. The entrance to the harbor had U-boat nets, which they would put up at night to keep U-boats out. So they had to wait outside of the nets. And then in the morning at around 8:15, they both set into the Narrows, which is this narrow strait here in between Halifax and the Dartmouth coast on the other side. And at around 8:45, they collided, and 20 minutes later, the Mont Blanc exploded. So here's the area of destruction. Like I said, it was the largest man-made explosion at the time. If you look at the bottom of the picture here, you can see the 2-ton Mont Blanc anchor shaft, which was propelled 5 kilometers to the south. And then at the top here, which you can almost see the Mont Blanc's cannon, which was propelled a little under 5 kilometers to the north. So the part of the reason this was such a disastrous event was while the ship was on fire in the harbor, a lot of the citizens of Halifax came out to look at it, because there was a fire in the harbor. And 20 minutes after the fire started, the explosion happened, and a lot of citizens were standing behind windows looking outside, and the explosion injured a lot of people. So 1,782 citizens of Halifax were killed, and there were around 9,000 injuries. A little aside here, Patrick Vincent Coleman was a rail yard worker, and many historical accounts attribute a reduction in the number of deaths because he made his way back to his post and issued a telegraph, which you see below: hold up the train, ammunition ship afire in the harbor, making for Pier 6 will explode. Guess this will be my last message. Goodbye, boys. Sent that to a train which was coming up full of children from Boston, and that train managed to stop in time and didn't suffer any effects from the explosion. So I thought that was pretty badass. So of course, Dr. William Ladd, the father of pediatric surgery, he went up to care for a lot of the victims. He was up there for about a month. They set out of Boston. Took about 5 days to get up there because of blizzards that were in the area. But he cared for a lot of children, and one of his fellows years later said that Dr. Ladd attributed his interest to eventually care for exclusively pediatric patients because of this disaster. So of course, 1927 published the first pediatric surgery started the first pediatric surgery fellowship at Boston Children's, and then in 1941 the first pediatric surgery textbook. And another interesting fact that I found is that around 72% of all pediatric surgeons in the country right now can trace their educational lineage to Dr. Ladd. So there's some of the children that were being cared for. And there's a picture of Ladd bands. Another interesting effect of the explosion, which isn't directly related to the talk, but the Christmas tree in Boston Commons every year is shipped down from Nova Scotia as a symbol of thanks. So that started about 10 years after the explosion, and every year they send it down on a truck. Costs them about $172,000 to ship the tree down every year. So that's pretty cool. So moving on, the Rialto Theater fire, 28 November 1921, New Haven, Connecticut. Not a ton of casualties at this. It was a picture theater, so early movies. 5 people were killed, 80 injured. A lot of kids here also who were there with their families. But Dr. Frank Powell Underhill, who is a scientist in the Department of Pharmacology and Toxicology up there at Yale, published a paper on their experience with the burn patients. And a lot of our knowledge of fluid resuscitation came from this initial paper. Even though Dr. Underhill wasn't a physician, he had a lot of insights into fluid resuscitation. And the concern back then was always that you'd fluid overload these patients, and this paper kind of quelled that fear. So a couple of years later, the Coconut Grove fire in Boston, which a lot of you are, I'm sure, familiar with. 1,000 people crammed into a space built for 600. At 10:15, a busboy was allegedly trying to replace a light bulb that a Navy sailor had unscrewed to have some more privacy with his date in the corner of the basement. So this busboy lit a match to try to illuminate the socket and ended up lighting all of the decorations that they had on the ceiling. And so within 15 minutes, the entire place was in flames. And completely destroyed. 15 minutes. One of the terrible things of this fire was the oxygen and ventilation systems. So at multiple historical accounts state that the fire would extinguish itself, and then as soon as someone would open a door and a fresh rush of oxygen came in, it would reignite, creating a ton of hot gases, which would kind of lay the foundations for the advances in inhalation burn injuries that we saw. So just more pictures of the fire. At around 10:30, victims started arriving at Mass General and at Boston City Hospital. So MGH got 114 patients and Boston City Hospital 300. Of all those, only 39 from MGH survived and 132 at Boston City Hospital. So I'll just touch a little bit upon why there were so many injured. So the Coconut Grove was not really up to codes enforcement standards. So a lot of the doors were welded shut to prevent people from entering illegally. And really the only two serviceable entries were the revolving door here where you see a 200, and then on the right side, the exit door onto Broadway, which you can see opens inwards as opposed to outwards. So within those 15 minutes, around 200 bodies piled up around the revolving door there and prevented a lot of people from exiting, and about 100 bodies piled up in front of the Broadway exit. So ton of advances in burn care from this. It was kind of a perfect storm. Dr. Oliver Cope and Dr. Francis Moore were at MGH, and they were actually doing some burn studies in DOD funded burn studies, because of World War II. And then, right, so they got, all these patients with a ton of inhalation injuries. So this was a new pattern that really wasn't, and it was observed, but they didn't really understand the pathophysiology of it. So it was a different pattern, this necrotizing tracheobronchitis, as opposed to the edema that you'd see in typical smoke inhalation patients. So there was a big contrast actually between this and the Cleveland Clinic fire, which happened, I think, 10 years prior to this. There were a lot of differences. So fluid resuscitation was a big thing here. It actually wasn't Dr. Cope and Dr. Moore, but at Boston City Hospital, Dr. Lund and Browder both were using new protocols for fluid resuscitation. Burn care, so the tanning process, which was kind of standard of care up to this point, was not used. Dr. Cope had kind of pioneered this boric acid petrolatum dressings where they'd apply them on these acute burns and leave them for up to 10 days. And previously the concern was that there was a lot of source of infection that could then lead to greater morbidity, but that wasn't seen. So in practice, this was kind of the first time that they were able to describe this. Antibiotics, this was interesting, and don't quote me on this, but I read a couple sources that stated this was the first time that penicillin was used in human patients outside of clinical trials. So all the patients were receiving antibiotics, and Merck in New Jersey actually sent up 27 liters of a penicillin IV solution with a police escort up to Boston. The London Browder chart, of course, arose from this. So they published that a couple of years later. And then codes enforcement, the NFPA and Boston Fire Department released an extensive report that then became adopted by many major cities across the US. So gross negligence, the owner was actually arrested and convicted of manslaughter. He was released a couple months after that because he had terminal lung cancer. So he was only in jail for a few months, but course, revolving doors now have to be flanked by 2 outward opening doors, and all exit doors in public buildings are outward opening and have panic bars. So some of the treatment of the patients and the London Browder chart. So next, we're going to fast forward 60 years. The Sandy Hook shooting, really terrible event. 20-year-old shooter entered the Sandy Hook Elementary School, Newtown, Connecticut, and murdered 26 people, 20 children and 6 adult staff. And in the aftermath, I'm sure a lot of you guys are aware of this, Dr. Lenworth Jacobs started what eventually would be known as the Hartford Consensus. So a bunch of professionals, from trauma surgery and public health, and a presidential commission were also involved in the Hartford Consensus, whose whole aim was to prevent mortality in these mass shooting events, which have become also common in the last couple of years. So out of that, the Stop the Bleed program started, which was a White House initiative aimed at teaching lay people how to be involved in hemorrhage control for patients of mass shootings, victims of mass shootings. So a couple other effects from this, law enforcement primarily. You'd be hard pressed to go around this country and find a law enforcement officer without a tourniquet on his belt. And 20 years ago, that was not super common. And this was actually one of the members of the commission went to the Major Cities Chiefs Association the year after the Hartford Consensus was published, and all the chiefs of the major police departments in the country kind of got on board and recognized that it was a responsibility of law enforcement to provide this initial hemorrhage control for these victims and themselves also. In EMS, there was the establishment of the yellow zone, which prior EMS would always stage in a secure location and then wait for casualties to arrive. The yellow zone kind of created this, or warm zone, where EMS would enter into maybe a not so secure location, but be closer to the casualties, and then could start rendering care immediately. So the Boston Marathon bombing, Dr. Caterson told me that, has taught me pretty well that everything that happens in Boston is perfect. So there were no lessons to be learned here.
You gotta get Kelly a comment. Keep going.
So the Mandalay Bay mass shooting, October 1st, 2017 in Las Vegas, Nevada. The Route 91 Harvest Music Festival, attended by a lot of country music fans, were the victims of a mass shooting from a shooter from the Mandalay Bay's hotel room. So there were 61 killed and 867 wounded. Now, there weren't many lessons learned from this, I think, but this is a perfect example of exactly what the Stop the Bleed program and the Hartford Consensus aimed to achieve. The death toll would have been a lot higher had it not been for a lot of civilian off-duty first responders, civilian lay people with no medical experience who prevented a lot of mortality that would have happened. The after action report cited this as one of the biggest mitigating factors in this event. So there's there's no studies that really can put a number to it, but you can read a ton of firsthand accounts of trauma surgeons in Las Vegas and other healthcare providers who are seeing patients arrive with like belts for tourniquets, a lot of other makeshift tourniquets. And so this was a good example of the lessons learned after Sandy Hook in practice. And that's my talk. Thank you. I'll take any questions now.
Dr. Kelly, is Boston perfect?
thank you very much for that interesting talk and a journey through history. I would make one quibble. Many of us in the audience have had a lot of mileage on the lecture circuit, pointing out what lessons you could have learned from the Boston Marathon. Dr. Caterson and I actually were there and collaborated on several patients, and it's been some years. One thing that's not talked about frequently in that disaster was it answered the question, what if they had a disaster and everybody was ready? It was almost a perfect storm of disaster preparedness, at least in terms of the availability of personnel from at every level. And it's a lot to be learned from the appropriate distribution of resources, rapid triage on the scene, and collaborative efforts from first responders and sort of back echelon providers. The one thing I would say is that the thing that we did wrong was we failed to recognize the injuries to the eardrum. There were more than 300 perforated eardrums in that blast, and most of them were diagnosed in the 7 days following because it was just something we weren't clued into and didn't make a priority of. But it was I think there is something to learn on that disaster on the good side, on how to get it right and what happens when you get it right.
Hey, this is EJ. Ed and I actually were in the trauma bay, and I'm gonna expose us for making a miss. And we're in the trauma bay, and I was taking down a tourniquet. I was going to go, and Ed was having a discussion with the ER provider that we got to go to the OR. The guy's got a tourniquet on. I took down the tourniquet, an arterial injury to lower extremity. And so I took him downstairs with Ed, and it turns out he had a ballistic go through his eye. He was 70 years old, and it was up in his head, and he's on Coumadin. And I think the lessons in the civilian mass casualty are that they are not the same lessons that we get from trauma battlefield injuries, meaning that we're used to an 18-year-old who, you know, is going to take that shrapnel and going to do fine and is not on Coumadin. And so there are some times that we have to check ourselves and say, wow, we have to look, we got a 70-year-old here. Is he on a medication that maybe would be deleterious? Because we always balance arterial bleeding versus the brain in trauma because it's designed for an 18-year-old. But it was just one of those things that sort of made me think about checking ourselves.
That's an excellent point. When I came to Boston from shock and the patients were 40 years older, it's a whole different world. But of course, that's not why they get such good results.
Also, in the modern era, it's ironic to point out that that particular patient was in his second injury in a separate mass casualty event. He had been blown up by the IRA in London many years before.
That's a very Boston story. Sometime when we're out for adult beverages, I'll tell you what happened when I went into the bar on Mission Hill when I was a resident, and it got really quiet. That was just a great talk. We always love to hear about Dr. Moore and the other stuff and how the Cleveland Clinic managed to give everybody cyanide poisoning when they had a fire in their radiology suite. We've got another talk lined up now. Our next speaker is Dr. Michael Bayme from Ben Gurion. Everybody be nice to Michael. He was my chief, so he still outranks me and always will. He's going to be talking about doing more with less because his weekend job is he's like whatever the Israelis call a colonel or a brigadier general in the IDF, and he goes out and sails around. Michael, you look marvelous.
Thanks. I'm at work, so I hope you don't mind the background. Does everyone hear me okay?
We can hear and see you just fine.
Okay, so I'm going to start then. First of all, just a comment on the previous presentation and the comments. First of all, it was a great presentation. I don't know how I'm going to try and do something as well as you did. Jamie sort of alluded to the fact that I trained with him in Boston in a time when there was no such thing as civilian mass injury. The only mass injury we had was some au pairs falling off a subway once or something like that. Always Saturday night, they're all Swedish and blonde. Jamie had a great time. But over the years, I've sort of morphed into a different sort of person. I'm living in Israel now 22 years, and I sort of had on-the-job training in mass casualties. And we all know, because most of the mass injuries are bombs, usually on buses or other contained spaces. So everyone suffers from a pressure wave. So we automatically check everyone's ears. We check everyone for hepatitis and all sorts of other viral diseases, which are sort of laced in pellets of these bombs. It's a big deal. And so my talk is making do with less, which is essentially the experience of the Israeli Navy. The Israeli army tries to basically emulate everything they can learn from the Americans. So way back when the Americans had field hospitals, or they set up field hospitals, so did the Israeli army. And just as it's a full hospital, it has everything you could possibly imagine. It takes about 30 standard shipping containers to move, which is why it was last used in the Yom Kippur War in 1973, where they did basically one appendectomy, and that's about it. So this dinosaur has, therefore, just for historical purposes, it has since morphed into the hospital, which is used for foreign operations. It's gone to Haiti, it's gone to Turkey, and various earthquakes, but it's not the object of the talk. But I was there for a while. Let me tell you, you can't use this for anything. So when they realized they can't use the field hospital, they set up something called Force 10, which I think is based on the movie. But it's essentially the same thing as the FAST groups that were set up by the US Navy. Basically, can you put a trauma surgeon, an anesthesiologist, an orthopedist on a Hummer and hope they don't get in an accident? Give them the same equipment as you would give a FAST team and see if they can set up some sort of mobile hospital. So we tried this and we set it up and we practiced like crazy, and we shot some sheep and we shot some goats. We don't shoot pigs because we don't operate on pigs in the Jewish state. But we set it up and we thought we had a really great working trauma system. The only problem is the geography. And essentially you're looking at a map of Israel and you're looking at all the various hospitals. The action right now is basically all around those hospitals. We have a great air evac team. There's no place on this map that's more than 7 minutes away from a major trauma center. So the whole concept of having a local trauma team is sort of passé. The people on the helicopter are usually experienced surgeons or anesthesiologists. They can intubate, they can give blood or chest tubes. And for a 7-minute transit time, it doesn't make sense to have local trauma surgeons. But that's all very nice and good around the borders of Israel. The problem is that the Navy, the Israeli Navy that is, has a huge range of operation. This is not the map of Israeli Navy, this is just a map showing you that essentially Israel is here on the map, and maybe a little bit is close enough for a helicopter evac. But in essentially a proxy war with Iran, the Israeli Navy finds itself all over the Arabian Sea and the Indian Ocean, which is all very nice and good. The problem is that we're very far away from any sort of support. We don't have any possibility of transfer of patients somewhere else. We have no friends in the area for practical purposes. And so we have to rethink how we're going to give trauma support to what are basically missions that are, it's no secret. Basically, you're trying to stop the transfer of missiles from Iran to various proxies on the Israeli border. It's an open, it's not a secret, everyone knows, it's been published, you can read about it. So in the ideal world, the Israeli Navy would have some sort of huge ship, like an aircraft carrier, with a trauma bay that's equipped and ready to go and operate whenever we could. In the real world, though, unfortunately, while the US has battleships, aircraft carriers, whatever, the Israeli Navy is essentially corvettes, which are down the bottom of the screen. These corvettes are tiny. And while the US has corvettes too, I actually was able to look up a list of all the corvettes in US Navy service, and here they are. This is the last time the US Navy had corvettes. And unfortunately, they don't help us. This is Israeli Navy Corvette as of a year ago. There's actually a newer version, but this talk is a year old. And the SAR 5 is basically the size of a football field. It has a hangar deck. It has 2 rooms that we can use for trauma. And that's about it. There's no place to set up and not interfere with the operations. Essentially, this boat is sealed. It's full of computers and a lot of electricity, and it's cooled down to essentially 0. It's not a great place to try and do trauma. So the question is, how can you take an environment like this and set up a trauma center, a portable trauma center? So it takes a lot of work, and I'll explain to you what the work is. So number one is that the trauma team are Navy officers. So in this country, if you're a doctor, you're in the Army. You can't turn it down. And you can try and get out of it, but essentially you can be like me, over the hill, not in shape. But if you have trauma experience, the Army can grab you. It's state law. Your boss at work, even in a socialized or private healthcare system, cannot refuse a request from the Army if they need you. So the trauma team is basically experienced surgeons, anesthesiologists, orthopedists, people who have a full-time job in one of the state hospitals, who are on a 4-hour notice. So I've been told that you have 4 hours to show up somewhere and be ready to go. So what we get are very experienced medical personnel with a crew that's a bunch of 18-year-olds who don't know any better, but since they're 18 and we're 50 years old and we're officers and they're basically young soldiers, they do what we tell them. And when we tell them we have to practice, they practice. And when we tell them how we have to move patients, we move patients. And somehow we manage to get things done. The thing to understand is that there is no option. Either the boat is in combat mode or it's in trauma mode, because we take all the available spaces. So once the boat is in trauma mode, everyone knows the kitchen is closed, the 2 rooms that we have are the messes. And so the crew has to understand all the regular activities, eating, relaxation, are essentially void until we take care of the trauma patient. The trauma team also gets called in for planning. And so we basically know what to expect, when to expect the casualties. The Navy does not operate for a long time. Essentially, they have a mission. We go out. It's a week or 2 of sailing. It's the expected mission, and then a week or 2 to get back, which is not good for family relations when you have 4 hours to tell your wife that you're leaving. But what it means is that before the mission takes place, one of the trauma surgeons and the anesthesiologists sit with the people who plan the mission, and we work around how can we make sure the boat is available to switch from a trauma mode or to a trauma mode in the middle of everything else that they're doing. And so just to point out, this boat has no room for us. Supposedly it's built for 71 people. Usually it sails with 100. And that means that the trauma team is tucked away somewhere in the corner. They don't give us a lot of room for equipment. What we can bring is blood. We can bring bear huggers. We can bring minimal equipment and use that to set up our trauma slot. For example, in anesthesia, we're really current with everything in elective colorectal surgery. Total IV anesthesia. We have no possibility of giving inhaled gases. The vents are the simple eye vents, very small portable vents, basic medications, 10 units of blood in the cooler. We have no invasive monitors because we have no room to set them up. Essentially, our operating room is the officer's mess table, and whatever you can do on that table, that's what you get done. So what can you do? Well, And I'll show you how we managed to do it in a second. So clearly, if you're setting up a very portable operating room on a small table without the extensive equipment, we're not going to do neurosurgery. We can do penetrating trauma to the lung, abdomen, and extremities. And we've managed to do that quite well. One of the ways we do that is by going back to, I guess, trauma surgery from the 60s and 70s. There's no angio suite, there are no stents. You have to relearn basically exposures of every blood vessel, starting from the clavicle and working your way down. Something which I have to say in residency, we didn't learn. Friends of mine in fellowship didn't learn, but for the purposes of operating on a boat, you have to relearn. The other thing we learned is that with 10 units of blood and a patient who you think is a trauma, you really don't have time to let the patient get into extremis, because once the patient is really in intractable shock, we have nothing to offer. We can intervene at, when it's clear they need surgery, but if we wait too long and we're sort of behind the 8 ball, we don't have the resources to bring them out of deep shock. We don't have enough invasive monitors. We don't have pressors on the boat. But what we do have is very bright people who are interested in preserving the patients. We have a lot of electricity and we have lots of communications. So what can you do? Well, a boat is cold. And by the time a patient is brought in, usually from another boat, they've been on a raft, they've been on some rubber boat till they're brought to us. They're wet and they're cold. So we developed our own solution. And this is the Roman solution to central heating. I don't even know how to pronounce it because my Latin is not much, but Jamie knows how to pronounce it. Anyway, what the Romans did was they built the fire in a platform beneath the area where he wanted to live. It radiated hot air through the building. And that's why the Romans could enjoy a hot bath in the middle of the winter. So while I'm not allowed to show you a picture, you can well imagine we don't operate directly on the table. We built a little platform above the table. We have a bear hugger, lots of electricity, circulates warm air beneath the patient. We use a regular bear hugger in the areas where we don't need exposure. And this way we keep the patient relatively warm, in a cocoon sort of, even though the boat is at 4 degrees Celsius or something, I tell you. And the other thing we have to understand is that we have physiology, basically working in our favor. The Israeli Army and Air Force, Navy are different from the Americans, American equivalents, in several ways. One is that the soldiers are essentially 18 years old. And you can do a lot with an 18-year-old that I wouldn't dare do with a 30 or 40-year-old. We have, permissive hypotension with us is a whole different ballgame. Something I wouldn't dare do in the hospital, I can do with an 18-year-old. Can leave them to blood pressure of 60, 70 for a while until we can correct problems, as opposed to an elderly person who would probably stroke or have a heart attack. The other thing is that the ideal American soldier and the ideal Israeli soldier are very different. It's sort of like the difference between American football players and Israeli and European soccer players. So I found a clip, which is probably a little bit racist. It's from an old movie, so please don't be upset if it's not directed to you.
Of course we can. We can do whatever the heck we want. Yeah. We just need to get it quiet. Okay. Well, let's work on that Sony ad. What can we say about Sony? What can we say about the Japanese? Start now.
Japanese. The Japanese, they're short. So their eyes are closer to the electronic components than many other nationalities. Caucasians are too tall and gangly. Look how far away the Caucasian worker's eyes.
Whoops, sorry. Okay, so what I wanted to make point here is that it's from an old movie, is that we are dealing with really perfect patients in terms of exposures. We have these really skinny, thin little guys. We can do a lot more with ultrasound than you would think with the regular trauma patients we see in work. Really thin guys, we can see blood vessels, we can do ultrasounds which wouldn't dare do at work. And the way we do it is we buy a lot of cheap Chinese ultrasound machines, and we spend our 2 weeks at sea practicing ultrasound on everyone until everyone in the team is really expert in every sort of ultrasound you can imagine. And since we don't have invasive monitors, we follow our patients with ultrasound, diagnose ultrasound, and we actually do a pretty good job of it. One of the things we do, which is sort of, I think it's fallen out of favor, is that we extend ultrasound pretty much through the whole body. We've become quite good at doing ultrasound of the ocular nerve and use that to, in place of CT scans, to follow intracranial pressure. I know it was big 10 years ago. It seems to have fallen off the trauma literature, but we still do it. It seems to work for us. So I'll give you, I'm not allowed to talk about cases, but I will give you one example. So 18-year-old soldier was victim of a blunt trauma, we'll leave it like that, somewhere off the coast of Somalia. He was actually hit in the head and hit in the abdomen and then thrown in the water. So he was pulled out of the water. Basically, he was vomiting up seawater. His blood pressure was low, he was cold, and he was barely conscious. He had no localizing neurologic signs, but he had an obvious head injury, and he had and he was clearly cold and he was aspirating. We did an ultrasound, okay. So now this is perfect patient, needs a head CT to see if he has a traumatic injury, needs probably a CT whole body to see what's going on, spleen, lungs, etc. Except that we are 10 days away from Israel by boat. There is no way a helicopter can make the flight. It's 4 times the range of our helicopters. And so we're a little bit stuck for what to do. So fortunately, we had lots of consultations and we talked about it. We decided without the blown pupil, we would not rush to do anything immediately. We intubated the patient, we warmed him up, we did ultrasound over and over and over. You could see the infiltrates on the lung even by ultrasound, so you got broad spectrum antibiotics. The abdomen, fortunately, was fine. And we actually did an ultrasound of the eyes, and just an example from the literature what you can see. But basically, we saw a normal optic nerve and no papilledema, so we just left the guy intubated and elected not to figure out some way to transfer him. And after 2 days with antibiotics, we were actually able to extubate him on the boat and sail back after 10 days, and he did fine. But there's no way you get away with this, first of all, in any civilian trauma, any trauma center. There's no way you could do this with an older person. And there's no way you could do this if you didn't have very experienced people on the boat taking care of these kids. So to summarize, yes, we have to go places that are far away with no support. You have to improvise to try and build a little portable trauma center. You can get away with a lot with young kids, and you should use the time to practice ultrasound over and over until you're really expert. Even though, on my oral boards, I said ultrasound, they want to fail me. So that's the scoop on how we manage to do things at sea. Thank you for letting me speak. And if you have a question, I'm game.
We do have one question teed up, and it's too bad that Dr. Tomiwa is not here because he was talking about ultrasound yesterday, but unfortunately he was busy fleeing the tsunami. So I'm not sure he's on the call right now. I have a brief question before I turn it over to Dr. Kelly, and I noted that the use of the term, Hail Mary helicopter flight. Is that IDF doctrine, or is that just your Boston training?
No,
rubbing off
no,
on you?
we were at a loss. You have a young guy, you want to try and save him. We were trying to figure out, to get a head CT, could we figure out some way, set up some system, beg Saudi Arabia for overflights or landing rights or something like that, to try and transfer back to some sort of trauma center. And basically we got nowhere. We were just too far away. We have nowhere to go. So
That's a very nice result. Dr. Kelly.
Good morning, Dr. Bayme. I thought that was a very enlightening and thought-provoking talk, particularly with the use of ocular ultrasound, which at Bay State Medical Center, we still are in the business of doing, although our EM colleagues primarily do the scans and interpretation, as we really don't have as much experience as the folks in the IDF. I would like to ask a question, though. Have you found, or are you interested in the use of Reboa catheters as part of the loadout for the hospital load for these ships? They're quite low profile and do not require advanced monitoring to place, and can buy you some time for those advanced vascular exposures that you referenced.
Okay, we actually have Reboa catheters. Just to point out that we cross-train with the Navy, and we've all been through the Navy course in USC with a great staff there. And so I was there in 2018. I think pretty much everyone is cross-trained with the Navy and has gone through that course. We've all done Reboas with them, and we have Reboa. I've not yet used Reboa on a boat, but I've used it in the trauma bay with much success. We're in fact, the Beersheba will be publishing a review of Reboa for the past 2 years, sometime in the near future.
Excellent. We'd love to hear more about that at a subsequent RMTS meeting.
Okay, next year, but clearly, I will point out, I thank you, first of all, for this opportunity. I also have to, apologize. I was supposed to give this talk last year. My father passed away, and which is why the talk was canceled. That's why I still have a beard. So it's a little bit delayed. But one point I have to talk about how in our residency in JAMA, we had no trauma essentially. And it's amazing how over 20 years of experience, you just learn to think differently and work differently. And so,
excellent. Thank you.
Working for Michael wasn't too traumatic. Dr. Caterson has a question.
Mm-hmm.
You mentioned that you didn't have any pressors, and one of the big strategies obviously would be bleeding control. But I'm asking the desert island question because what do you take with you? Did you take TXA? I mean, I'm trying to think about the strategies.
Yes, don't ask. For some reason, when something is big in literature, the Israeli army goes and buys it. So when TXA was big, they bought enough. When Factor 7 was out, we bought Factor 7. I don't know. When the little iStat portable chemistry machines came out, we bought portable chemistry machines. But in practice, we give TXA. We've yet to use Factor 7. We never really found a real reason for it so far. Surprisingly, I thought all our patients would come out of the water would be cold and maybe bleeding tendencies, but I haven't found that. Somehow the young guys don't seem to have as much bleeding problems in the cold as our older patients. Like I said, you look at the American Army, which has more professional soldiers. I've met some of them when they've been stationed in Sinai and various injuries. And these guys are 30, 35 years old, even 40 years old, and they're still in the Army. Our soldiers are 18, 19, 20 years old. And we get away with a lot more than you would with older guys. Food for thought.
Now we're learning about IDF doctrine on patient selection. We have time for one more question.
Absolutely. Great presentation. I enjoyed it. In my years of experience, peace is the best hemostatic agent. We don't tend to try it, but it works. I want to know a little bit more about your doctrine, your doctrinal structure in terms of how far away your fast support is for your troops. So if your troops are operating in a certain ring, what is the mileage of support that you have to be in by doctrine, and what's the reality?
Well, the reality is very clear.
You're muted.
If we are in helicopter range, and unless the patient is just crashing in front of us, we transfer. So, the basic helicopters have a range of 300-400 kilometers, let's say 200 odd miles. So anything that happens in Israel proper, anything that happens offshore, up until basically the various lines of international rule, basically are in helicopter range. And so we don't do anything, extravagant. We just try and pack them up and send them wherever we go. Even in the, before I was in the Navy, I was in the ground forces, and even in the war in Gaza in 2009 or so, we had all sorts of setups on the ground, but because everyone thought, the Hamas in Gaza has so many missiles, they're going to shoot down the helicopters. But it turns out we were able to evacuate everyone on helicopters immediately. And so we did nothing on the ground. What's that?
What are your in-air capabilities?
Basically, blood and patients are, if they need to be intubated, they're intubated on the ground before they go on the helicopter. At the same time, lines, cricothyroidine, whatever can be done immediately is done. They can get blood in transport, antibiotics, TXA, anything else you want to give, can be given in transport. But the transport time is minimal. We're talking about, most of anything close to or on proper Israel is 7 minutes away from a trauma center. So there's really no reason to do anything more. If you need to protect the airway, give some blood and run. It's just once you're beyond helicopter range, then it gets interesting.
Michael.
Okay, thank you so much.
And, obviously, we're terribly sorry about Pop, but we are glad that you were able to make it here this time, and hope this is one of more. I will point out that in the interest of regional representation, I've been calling all over the place, and you're the only one who's been able to make it. I went to medical school with Fudlo Curry, who runs AUB and is a medical oncologist, and he seems to have his hands full for some reason. We're going to shift now. Dr. Caterson, who spoke to us and fascinated everybody with his thoughts on team building, is going to be giving us, I think, some cases in a talk entitled Pit Bulls and Parolees, which sounds a little bit like my clinic. EJ, let it rip.
I'm still reflecting on Dr. Simpkins' question yesterday. How do we facilitate other members, the radiology tech, to communicate with the surgeon? And I was brushing my teeth, sort of troubled by that conversation, and thinking that that was such an insightful discussion. As division leader, I basically occasionally have to intervene and tell people not to do things, but very infrequently. And I'm not good at that. And so I don't think that we, even though we serve these leadership roles, do a good job asking for input from every member of the team. And so I'm going to reflect on that and go back and actually invite more discussion. So I really appreciated that question yesterday. So, all right, well, 2 years ago, I moved down to Delaware, and the penetration of pit bulls is tremendous in my community. There's a history of dogfighting in my community, and I actually was surprised by the number of dog injuries. And we'll talk a little bit about sort of the scale of injuries. Yesterday, you had Simon Talbot, who, when he was a first-year attending, came into my clinic because I was the craniofacial surgeon at Brigham, and said, "What do I do with this?" And I asked him, "Well, where's the part?" And he said, "The dog ate it." And I prompted him, because I had a chief resident with me. I was like, "Call the police and get the dog." And so they did take that dog out. We got it out of the dog's stomach, and it was in the stomach for 4 hours. And Simon presented this last year, but we did replant it. I'm very familiar with this case because I started my birthday with this case. I finished my birthday with this case. Unfortunately, we got it to live for 5 days, and it had I think we had something like 100 and I don't know, there was like 18 centimeters of micro, because we jump graphed it like 3 times. We had it like on life support back and forth. We didn't have good veins on it. And eventually Simon and I had to reconstruct her conventionally. But, you know, because that piece died like a dog. But anyway, one thing about soft tissue and dog bites, and then another dog bite, is as a plastic surgeon, one of my lessons to any colleague is always don't rush in. And you guys always laugh at us when we're like, you know, we're like, "Oh, that'll be fine." And what I mean by that is that you do a little thing, but you don't do anything here that's going to cause a permanent contracture, and you let the body work on it. So that I come at 4 weeks and take that same patient to the operating room 4 weeks later, I'm going to go back. All I did was tack a little bit of side stuff together, try to set the commissure, walk away, that's in the ER, and then let the contracture happen so that I can go deal with that contracture and put that person on 4 weeks later. And so, you know, or 8 weeks later, I guess I waited even longer. Depends on the OR schedule. But so, you know, but we see these types of dog bites all the time. And, you know, this one was a shocker. So 4th of July, Salem, New Jersey, which is across the river, below Trenton, below sort of Philadelphia, Camden. It just sort of is on the way. Impoverished community. Kid lives in a project or government housing. The only open grass is between the 2 buildings. The man who owns the apartment on the corner believes that's his grass, and he doesn't like the children playing there. So he releases the pit bull on the child. This child comes in like this, and, you know, it was a vicious injury is what I can say. We learn lessons from all sorts of surgery here in what we do. And being that as a plastic surgeon, you train in hand surgery. I drove a MyTech anchor back in that corner up by where the medial canthus should be, and basically drilled MyTech screw anchors into the ethmoid. And that's where I'm showing how I'm putting a bishop down to sort of guide where I'm going to drive the MyTech, and got him into a reasonable status. He needed a levator recession, but the kid's pretty much back to where he needed to be. But it goes back to, you know, we get lucky sometimes, but the point of this is that what's awful is the idea to think about, why does this happen? So one of the things that Theo's been doing is he's been looking at a nationally weighted probability sample in the United States, and wanted to ask the simple question, and this is the national, the sample that we use is NEISS. And what you want to do is you want to say, okay, in COVID with a bunch of dogs, our hypothesis was, did we have more dogs after COVID puppies or not, more dog attacks? And so let me put this in perspective though. Measles, mumps, rubella, children, dog bites eclipse all of that. So in the United States, there are, let me get this right, 54 million dogs. There are 900,000 dog bites per year. Now, 500,000 of them, so greater than 50% of those affect children because where they are. and 25% of dog bites that affect children, so 25% of the 400 to 500,000 require going to a hospital. In the United States, the other 500,000, the adults, only 12% end up going to a hospital. So in a pediatric population, the dog bites tend to be worse and they tend to be more aggressive. They're usually related to different breeds. And what I want to show you is the adjusted odds ratio after COVID was that you were 2.6% increase. And the number was actually pretty dramatic and correlated well. 2015 was our baseline. And I'll show you hard numbers as well. But the long and short is that what happened is the number of dog bites went up tremendously. I looked at the division's work, and in a normal year, 5% of the division of plastic surgery is about dog bites. It was up to about 7.5%. And you know, what happens when you look at that at a national level is you ask yourself and say, is any of this preventable? You know, we go back to the seatbelt discussion, right? You had a bunch of motor vehicle accidents, you're seeing horrible injuries. We said, what do we need to do? There's a constant discussion about the 87,000 gunshot wounds in the United States about gun safety. I don't hear the same conversation for the 900 to 1 million dog bites in the United States, that there is a sort of a graduated or comprehensive methodology in order to think about prevention. And so, you know, these injuries, when you look at them at the, you know, initial baseline, you're like, okay, well, that doesn't look that bad. You stitch that up. But, you know, that is a through and through bite from a pit bull driving through the parotid with a facial nerve injury. You know, at first blush, it doesn't look bad, but there's a lot going on, and it's usually the face. If it's not the face, it's at least the hands, and there's little high value structures related in the hands and the face. And so these kids end up with bites that, you know, require, this is a replant of a lip. I couldn't get the venous scenario situated, so I had to leech that one. And leeches on the face are always a big crowd pleaser, but eventually you can get some patients back. This is our trauma center, and you look and say, okay, what's the distribution? And I'm at a level 1 pediatric trauma center now. Fall 46%, MVC 18%, bike 9%, 8% neglect abuse, which is again a whole different discussion and a talk for another year. But you look at that, and 5% in a normal year is dog bites. And then in COVID, that went up to actually jumped up to around 8%. And, you know, I think about that and think, wow, we have work to do. So when you look at our patients, not that it's a huge number because we're not, you know, an incredibly busy center, but 6.3% of our unique medical records on average were dog bites. This is not a polytrauma, and you can see that we went up, that it was taking up about 6.5%, 5% in a normal year of our divisional activity. And I look at that and say, all of this activity, you know, it's not that big of a deal, but these injuries are life-changing sometimes. They leave permanent scars, they leave, you know, what have you, disability, and make us do all sorts of different things. But I look at them and say, it needs to stop. And I don't know how to get at it. So I think the first identification is identify the problem. And that's what we're doing academically. Frame it in a context of a population. And then the next iteration of that is, how do we get to a point of advocacy and say, where do we get responsible dog ownership? Where do we understand how to sort of not curtail anybody's individual freedoms about what breeds to select or what have you, but to provide education based upon it. And so I appreciate all of you guys. I love coming to this meeting because it's a small meeting. I feel like we can actually have meaningful, open discussion. And the only reason to give this talk was really to get your thoughts on how do we go to the next steps on prevention. So I appreciate you all and would appreciate your insights. So thank you very much.
Well, I think that excellent talk. really a very important area that we don't look at or think about very much, but it's quite extensive, as you say. We have a mental health crisis in this country that's not addressed. We have a lot of people with a lot of mental health problems. I mean, when I did my violence intervention program in Buffalo, we gave the no, I did it in Baltimore first, and then we did it in Buffalo. We gave this psychological screening. I forget now, Minnesota. I forget what it is now, but we gave this test to people, and we found very little PTSD. We found a lot of schizophrenia and depression and all kinds of mental health disease, and the majority of them that was just untreated. And we're just not taking care of our people. And there are a lot of people who are on the edge. That's my explanation for it. I mean, why would you stick a dog on a child? It's incredible. But we're not taking care of our people, and we have the resources to do it, and we're not taking care of them. We're not doing the physical health. I mean, my goodness, Cuba has a lower infant mortality rate than we do, and they have a longer life expectancy than we do, and they're embargoed. I mean, does that make any sense? I mean, so it's what we vote for. So that's all I got to say. That's enough political stuff for me.
Yeah, EJ, I think a question would be for those dogs that are attacking in this manner, why did the owners choose to purchase them? Is this a matter of defense? And if there are dogs that are being purchased for defensive reasons, then what we know from the data is that not many of the pictures that you showed of children or coming in people's homes robbing people. So then there's a discorrelation. There's not a correlation between the injuries and what the dog is purchased for, and then we can go from there in terms of how do you do dog education, which is pretty reliable. I mean, we do train dogs in the military, and so we know that there's a capability of creating a set of orders and instructions by which dogs can comply with.
I think you're right. I think that in our community here, Wilmington, Delaware is the inner city of Wilmington, Delaware is a place that has a high crime rate. And I think that people unfortunately purchase a pit bull because they think that that's going to give them some measure of protection to home invasion. But the downside of that is that the children live in the home, and it's usually the children who are, unfortunately reaching for the food bowl or whatever it is. And, I have to tell you that as my job, and I come in and I go, what happened? I just ask that simple question, and, I get all the range of answers from, she was messing with the dog's bowl. And at that point in time, it is so painful as a surgeon to see, some permanent scarring on a 5-year-old girl that has just been ripped apart because she messed with the dog's bowl. And I don't have a solution as a surgeon. I just say, roger that, go in and do my case, discharge them from the OR, and think I haven't solved the problem because that's coming back.
Do you think some publicity would help? Some publicity? I mean, the public's not aware. And maybe, I mean, this is a news story anyway. And, the news industry is very opportunistic, but this is a story. And maybe people were aware of it. It might help. But we got a lot of problems, people are boiling point.
What price are the owners paying?
None. I mean, none. That's I guess a good point. Is the
So
owners
that's the
aren't
first
paying
place to go, because when the owners go to jail or
Yep.
get hit with what's even worse than jail, a big financial, just have them pay the hospital bill and some damages to the kid for life.
Yep.
Then, they'll speak with their pockets.
But Avi, as EJ points out, a lot of these dogs are the family dogs. The owners are the parents of the injured child. And they have to deal with the guilt and the financial liability of medical care for lots of this reconstruction. So I think, as Tuffy points out, it might be better to make people into better dog owners.
Yeah.
You know, I've owned pit bulls for the last 20 years. And I think if you're a responsible dog owner, this sort of thing doesn't happen. But at the same time, there is no restriction. It's much like a gun. You can buy one anywhere, you can operate one however you like. And people just, I think, don't have a good understanding of how dangerous a poorly trained animal in the house is. And I think we would be well served to coordinate efforts to help people understand how to take care of their pets.
But Ed, tell me something. I mean, you say you're a pit bull owner. Why a pit bull and not something else? I mean, why that choice to begin with? Because you're a rational person. I
only get rescue dogs, and most of your rescue dogs are pit bulls. And we usually buy our dogs from services that will bring them out of a kill shelter and bring them to homes that want them and can take care of them. Again, you have to have some understanding of how to raise a rescue dog. They have lots of issues with trust and will, become aggressive if they're not carefully trained out of it. A dog that's aggressive towards a human being is dangerous, no matter what the breed. And therefore, it's important to train that dog that aggression towards human beings is not tolerated. Unfortunately, many of these dogs are being trained to be physically aggressive towards people, and that's irresponsible. Everybody knows that.
Maybe we should require a different type of training if you're going to have a dog,
I think that would be great. The amount of abuse you see towards animals translates into the abuse of children in the home by the animal.
Yeah.
And it's another cycle of abuse that we've seen.
Straining
This dog this last kid I'm showing, it was the grandparents' dog. And the grandparents' dog was a pit bull. It bit the older child already 6 months earlier. And then it did this to the kid. And the son and daughter-in-law were like, you have to get rid of the dog. And instead, the grandparents no longer see those family members. So I don't even know what to do here. I can't fix this kid, as you see. I mean, it's lifelong.
Going back to anecdotes and people wondering about breed specific issues, which is just super difficult because there's no real data, and some people who wish to breed dogs for aggressive behavior gravitate towards certain breeds. Regarding Hazel, Ed's dog, she's a sweetheart, but scary to look at.
Oh, come on.
So Jamie brought up a really interesting point. So PETA made us stop monitoring what dog breeds actually cause the injury patterns. But Theo's looking into that because our own personal data has some marker of it and data, and it's 70% pit bulls. But that's why I titled the talk that way. And it may just be a local phenomenon because when I was in Boston, we did not have the same penetration of that dog breed. So, I think that there's regional differences in dog ownerships, but we're trying to scratch that, and we'll get more into that. But it was, I think, somewhere in mid-90s that they stopped recording the breed as part of the injury pattern because they thought that created biases.
So I would make a parallel between the NRA and PETA. And the left and the right can have a party together because it's different people, but it's the same shit with different political agendas. And I'm sorry to you, Ed, but I think that pit bulls should be put down and that humans shouldn't breed them. And I have no understanding at all, as somebody in the middle of the road, not on the right, not on the left, why the hell anybody would need a pit bull and why we would want to raise more of them and protect them.
Outburst noted.
And that outburst is the same thing about wackos owning guns.
Well, and to EJ's comment about like local patterns, they do vary a lot. When I was in Grand Junction, the only dogs anybody had in Junction were Pedis and Chihuahuas. And it's not like Chihuahuas are the friendliest breed in the whole world, you know, as long as we're generalizing about breeds, but you know, they are puntable. So way fewer significant injuries.
All right, I would encourage you
What do we
guys,
do?
'cause
Yeah.
you guys are all in the trauma world much more than I am. And again, looking at the trauma data, we had about 5% of our trauma work was dogs in the pediatric trauma population. And you guys have advocacy about trauma because I'm the second level provider. You know, nobody really, like the plastic surgeons getting called after everybody's cleared and you're blah, blah, blah. I do think that there's a role for organized trauma to make some comments about this, especially at the pediatric level 1 trauma level. There needs to be some advocacy here. I mean, everybody agrees that, oh my gosh, you know, but it exceeds, you know, wearing a bike helmet. Dog bites exceed that in every level 1 pediatric trauma center. And so along the lines, I think we need to do some advocacy as a profession. That's all.
That's an excellent point, EJ. And the beautiful thing is there has been some discussion of the Mayo brothers this morning. And our next speaker, Dr. Pedi, hails from Rochester. I don't know if she's actually there at the moment, but she's a pediatric surgeon at the Mayo. And so she may well be able to comment because there probably is saturation on giving out bike helmets at some point.
Hello, I am here. Thanks for having me. Can you hear me okay? You can hear me okay?
Yeah.
All right, great.
So EJ just presented a series of mostly facial reconstruction problems after canine bites.
Mhm.
And we were talking about what to do about it because the incidence was so high. It's 5% of his volume.
Mhm.
And he pointed out that's a lot bigger than a lot of other public health problems about which you hear a lot more.
Yeah, for sure. So I'm a pediatric surgeon, so and have been at a few different for training and now practice level 1 centers, and we certainly see too many injuries from dog bites. I'm also a German Shepherd owner myself. And I don't know for sure, but I think at our institution, I think it does vary regionally, because I can tell you other places we saw more in proportion to what we see here in Rochester. We definitely see more of other types of things. And I'd have to look, but I would be surprised if it were 5% here. But it's still terrible every time it happens. And agree that you hear nothing about it in terms of advocacy compared to some of the other things. The other thing that always surprises me when these patients come in is we don't have a great way to deal with the rabies situation. A lot of times the vaccination status of the dog is unknown, and I've seen a ton of variability in how that is handled. You know, sometimes it's, well, we're quarantining the dog and that's enough, you just watch them, whereas other times it's injecting stuff at the site of the bite to try to prevent rabies because we don't know the status of the dog. And that seems to vary just by institution and who's there that particular day, which is not optimal. That's the other part of it that I've noticed that I think we could improve.
Thank you very much. By the way, since we haven't spoken directly before, did I pronounce your last name right?
It's Pedi. I don't remember what you said, but it sounded fine. Yeah.
I was close, at least. Well, Dr. Pedi is a pediatric surgeon at the Mayo Clinic who's going to be talking to us about resuscitation. And I'm sure that everybody's interested in that. And we have some people on this call, like Dr. Simpkins, who have devoted their lives to the problem. So feel free to share your screen and get going.
Yeah, will do. Okay, great. So yeah, I already said I'm a pediatric surgeon in Rochester. at Mayo, and some of my my clinical and even more than that, because all pediatric surgeons do pediatric trauma, is transfusion and resuscitation in children. So just going to talk about some of some things in the field in general, some of our own work too. And so the reason I wanted to talk about this is pediatric trauma, because I think of the relatively lower frequency of injury compared to adults, usually lags behind in terms of research and even practice. And resuscitation and transfusion has been no different. The most recent ATLS version is better, which I'll talk about, but even up to a couple of years ago, it was still recommending 2 crystalloid boluses before blood for injured children. Meanwhile, in adults, it was to go to blood right away, and then even go to plasma right away before red cells. We didn't know sort of if children have the same implications of having too much crystalloid that adults do. It's a little bit trickier in children too, because everything is weight-based. So a crystalloid bolus in children is about 20 mLs per kilo. If they're adult size, then you can give them in the liters, but often, you'll find children getting a lot more crystalloid when you consider by weight than it seems like they're getting if you just look at by liters. Blood transfusion is typically 10 or 15, even 15 mLs per kilogram, which the equivalent of a unit in adult can be much less than the actual unit at your facility. I talked about this a little bit, but while we were still recommending 2 crystalloid boluses before going to blood in adults, the recommendations were to give blood first, minimize crystalloid, give balanced transfusion, and even whole blood, which is now subsequently taken off in a much bigger way. So there were the initial studies really in this were in Department of Defense data, pediatric patients from Iraq and Afghanistan, and they found the numbers, unfortunately, the sample sizes were much bigger than anything that was published at U.S. trauma centers. When they looked at crystalloid administration in the first 24 hours and the outcomes, are the different lines, they found that with the jump of 0 to 50 to 50 to 100, the hospital days, ICU days, and ventilator days went up. And this was significant. And then there was a subsequent, another study that showed basically the same thing, that if you got more than 3 crystalloid boluses, you had greater ICU length of stay, hospital length of stay, days on the ventilator. So this concept that children are sort of immune to the adverse effects of too much crystalloid was being a little bit disbanded at this time. And then, so if you can't give them too much crystalloid, this is a study, this is from Pittsburgh. They looked at children who were hypotensive in the trauma bay compared to those who were not hypotensive, and they had worse survival, which is a little bit intuitive, but it just shows that you still do need to resuscitate these children somehow, because once they're hypotensive, they already have an increased risk of dying. This is from the 10th edition of ATLS from 2018 that acknowledges the movement in pediatric trauma towards crystalloid restrictive and balanced blood product resuscitation in children with evidence of hemorrhagic shock, which is a whole nother point on its own, because we don't really know, we don't have great preliminary indicators of hemorrhagic shock. And they acknowledge that published studies supporting this approach are lacking at the time of this publication. So they knew that too much crystalloid is not good, under resuscitation is not good, but what can we do to optimize resuscitation? I'm going to talk a little bit about some of our work that we did with other centers. We looked at what is the relationship between the number of crystalloid boluses and the need for transfusion at our own institution, and then Hennepin County, which is in Minneapolis. A little bit, Mayo is rural. Most of our patients, well, at least half of our trauma patients are transfers in from the region. Hennepin County is a little bit more of an urban population and less transfers than we have. So when we looked at the number of crystalloid boluses by their transfusion need, it really plateaued after that first bolus. By the second bolus, giving additional boluses really didn't change their need for blood. Almost half of those patients still needed transfusions. And then we also found that additional fluid bolus was associated with an extended ICU stay and extended hospital stay. This is retrospective, so it doesn't prove causality, but it certainly was concerning. Then we did a much bigger study, including all of these wonderful pediatric trauma centers to confirm our findings and get a little bit more information. And this was done in a prospective fashion as opposed to retrospective. And patients, children, we define child as less than 18. They had to come directly from the scene of injury because it's too hard to get resuscitation data if they were at another institution first, which is a limitation. And we used an elevated shock index as an inclusion into the study. We ended up with about 700 patients, but we did have to exclude almost that same number because they were transfers. We found some interesting things just about the epidemiology of resuscitation in pediatric trauma. The first numbers there are for the pre-hospital environment. Very few patients relatively got anything in the pre-hospital environment. And remember, we're only including those with an elevated shock index. Less than 1% received pre-hospital blood. So that practice certainly isn't as widespread as it is in adults. In the hospital, almost half got crystalloid, 21% got blood, and 10% had activation of that hospital's massive transfusion protocol, which is also interesting. And it kind of shows that shock index alone is not nearly enough in children to identify who is really in hemorrhagic shock. And then we found the same thing when we looked at the transfusion rates, which is on the y-axis, and the number of crystalloid boluses. Once you get to the second crystalloid bolus, almost half of those patients require transfusion, and that doesn't change with additional boluses. We also found again that crystalloid was associated with greater ICU days, ventilator days, and total days in the hospital. It was not associated with mortality, or in-hospital mortality, I should say. So we concluded that more crystalloid is harmful. If patients are not responding to the first crystalloid bolus, give blood if it's available. And then we also found that patients who received blood first before any crystalloid, of course, they had they had a shorter time to transfusion. They also had a lower total fluid volume requirement, including blood or crystalloid, which is interesting. So this is something that we thought would be of interest for future study. The ATLS 10th edition supports these notions. They note the adult practice. They support giving blood first or right after the first bolus if it seems that the patient has hemorrhage. So what does this mean practically? In the pediatric trauma community, it seems, it's not written in stone, and there is a consensus conference coming up in the spring, where I expect more of this will be hammered out. But it's pretty widely accepted that if you have a severely injured child with physiology suggesting shock and blood is available, give blood. It's pretty much now, if you don't have any response to hypotension with the first bolus, then you definitely need to give blood. And if a lot of us are receiving patients that have already been treated at another facility at which they may have received crystalloid. So if they received crystalloid and their vitals are still abnormal, give blood. And not every transport transport system for pediatric trauma patients have the ability to give blood en route, but you can work with them to take blood from the referring facility if needed, because they really want to avoid that hypotension. So, I think we know now that that crystalloid does become harmful at some point for children, and you don't want to give more than one bolus. And that probably subsequent data are going to show that that giving blood first in those patients who are truly bleeding is helpful. But the problem is that we don't know how to identify these patients until afterwards. In adults, they use the ABC score and other things. It's not panned out in children. And then in Denver, they published, the pediatric age-adjusted shock index, which is awesome because it helped a lot and it's narrowed down the population quite a bit. Shock index is heart rate over systolic blood pressure, and then there's an age adjustment that occurs that they have published. However, despite us using this in our larger study, still only a small portion of those patients ever got blood. And most of those that didn't get blood they didn't die, nothing bad happened to them. So we need something that is a little bit more accurate to identify these patients. And that is an ongoing active area of research. The other thing that we don't know is how to transfuse. When we say give blood, what does that mean? We don't know the optimal ratio of products. We don't know if we should give plasma or red cells first. We don't completely know how useful TEG or ROTEM is. And we don't know what the optimal utilization of whole blood is. Over on the right, I just included the age-adjusted shock index. Children are usually pretty distressed, just not only because of injury, but because of the trauma resuscitation in general. It's stressful. Their families might not be nearby. So they have a lot of reasons to be tachycardic. And so you can get false positive shock indexes because of that high heart rate. So to start addressing the first thing, who needs blood among the pediatric population? There have been a multitude of clinical indices developed and studied to try to predict this. Most are kind of carrying on with the age-adjusted shock index concept initially published by Denver, inverting it, multiplying it by GCS, multiplying it by GCS motor score. There's including that and the systolic blood pressure alone, and they all show fairly accurate prediction. We just, for whatever reason, and I don't know if it's complexity of the calculation or whatever, it's not been widely integrated clinically, and they have not been validated prospectively in a multi-center fashion, which you need, considering the number of severely injured children that require massive resuscitation. Even at big centers, it does not give you the numbers that you need to have adequately powered studies. So these continue to be developed and presented and published and show promising results, but I think for a multitude of reasons, they haven't been widely adopted into our clinical practice. So then ratio of blood products, Department of Defense data was the initial data on this, and it was great data, and it had higher numbers than anything from US trauma centers. They showed no difference in outcomes with the high plasma to RBC ratio of transfusion. Subsequently, there have been studies done both using patients from the Trauma Quality Improvement Program and Atomic, which is a group of basically a research collaborative between several level 1 pediatric trauma centers. They actually did find a benefit to high ratio transfusion. These are all retrospective studies. All of these studies have significant selection bias, mostly because they only include patients who meet criteria for massive transfusion, which the most common definition for that I've seen is greater than 40 mLs per kilo of blood. And so you're only including the children who had the opportunity to get that much blood. We don't know who potentially would have benefited from that much blood, but just didn't get it. So we really need prospective studies to better analyze this, which are underway in the field for sure. And then platelet administration has just been too rare to study in anything. When you look at the percentage of patients who receive platelets, even among massively transfused, it's really low. So that's another sort of hang up in the field currently. Thromboelastography, so TEG or ROTEM, if that's what your institution uses. This has been, this is typically part of the, level 1 trauma labs or level red labs, whichever your institution uses, if you have it available. But what does it mean? Adam Vogel in Texas was sort of one of the first to publish on TEG, and he showed that there's actionable data on the table on the right. You can see that there are significant associations with the different TEG values and needing early blood product transfusion. This is more recently that they looked at, again, the TEG values and predicting needing transfusion and major interventions. Interestingly, the only significant thing on multivariable analysis, which is the MA, which mostly reflects platelet, the need for platelets. And this is, platelets are the one product that it seems like children rarely get. So if anything, it seems like TEG might be most helpful for helping to remind us to give platelets. But more studies are underway. All of these studies have relatively low numbers compared to any studies of TEG or ROTEM in adults. And then the other thing that we have to consider right now is, what is the role of whole blood? We know whole blood is back again and seems to be very helpful. And what is it, and what should we be doing in children? Actually, it's also being used in cardiac, congenital heart surgery, probably even more than pediatric trauma right now. But there's a lot of interest in this, and a lot of programs that are now allowing whole blood down to even in infants. Currently our practice is we can give it to any child that is at least 6 months old. This is a study from Pittsburgh that was published in Annals of Surgery in 2020. They had 28 patients who received whole blood. They propensity score matched 28 patients that received component therapy, and they found that there was faster correction of shock, lower post-transfusion INR, and decreased total component requirement, but did not find difference in subsequent outcomes, including mortality, which is not surprising. When you have these low numbers, it's really hard to show a difference in those outcomes, especially mortality. Subsequently, this is Department of Defense data that looked at whole blood. They again I think they had 23 patients that received whole blood out of many more, I think like 800 that received transfusion. They looked at survival, and these are multivariable analyses. On the left, it's looking at all of the patients, and whole blood was not significantly associated with improved survival. But on the right is when they excluded those with severe head injuries, which I think was 3 of the 23, and they did find a significant difference, which, you could surmise that those head injuries were probably non-survivable to begin with, and so when those were taken out, potentially there is a benefit to whole blood. We, as I said, just to kind of skip ahead here to the takeaway points from all of these things. We don't know for sure the answers to these, but what we seem to be doing practically right now is many pediatric trauma centers now have whole blood programs, and even adult trauma centers that treat children. And I've heard varying ages that goes down to. I talked to a colleague in San Antonio recently, and they're giving it down to about 2 years of age. We've just lowered our age to 6 months, but it's not always available. Sometimes we want to give it and it's not available, or it's not available in the specific blood type that the patient has if we want to give cross-match blood. So it's not a replacement, but I certainly, in my practice, when it's available, I use that preferably to components. And then, if you can't give whole blood, we are starting to do balanced transfusion, at least with plasma and red cells. We probably don't give 1-to-1 with platelets as well. But honestly, it doesn't come up that frequently. So we are certainly looking forward to some of the prospective studies going on currently to help us with this practice. But if you have a patient getting a lot of red cells, give plasma, give platelets. We are using TEG on all of our severely injured patients. The problem that we run into sometimes is everywhere, treating a trauma patient and a pediatric trauma patient especially is a multidisciplinary effort for sure. And so not all of the areas that the patients go, or not all the people taking care of the patients, may be familiar with TEG or ROTEM in children. So that's also a little bit of a barrier in it. So you have to be ready to help your colleagues interpret what it means and what to do based on it. A lot of the reason that these data lag behind adults so bad is that there's significant barriers to prospective interventional studies in pediatric trauma. At any single institution, you're not going to be adequately powered. So you have to then get it up and running at multiple centers, which has a lot of logistic challenges. When it comes to consent for this, you can't consent the patient, you have to consent the parents, but how do you consent the parents during the trauma resuscitation? So then you're dealing with a delayed consent situation. So it's a huge challenge. And that I think that's part of why, but nonetheless, it is pushing forward. There are multiple prospective studies that are ongoing to try to better clarify that. But I think there's enough data, at least at this point, to change our practice from what it was a couple of years ago, where you gave multiple crystalloid boluses, patients just got red cells and weren't getting plasma or platelets for a long time, and TEG wasn't really a big part of it, and nobody got whole blood. So I think we can start incorporating some of those things at this time. That's pretty much all I had, but if there's any questions or discussion items, we'd be happy to stay on.
I think there are. I'm going to have to whisper for a second until we solve our sound problem. Thank you, Dr. Williams. I apologize for throwing you into the pit bull fray as you were logging on, but you pointed out regional differences and then ended your talk pointing out that since it's raining lemons in terms of small numbers, you're making lemonade by doing all these multi-center trials. And I think that's just absolutely wonderful. I know that Dr. Kelly has a question for you.
Mm-hmm.
Thank you, Dr. Pedi. I thought that was a very enlightening talk with a lot of explanation of some confusing trials that have been appearing in the literature. I have noted here in Western Massachusetts a severe shortage of available blood for transfusion, which traces back to the prolonged pandemic. I would like to know if you and other members of the society who are on are experiencing the same thing. Our blood bank is now gatekeeping every unit of blood we order and is giving us exactly half of what we've prescribed. I think this could make a significant problem for the pediatric population, especially, and how we could potentially think of ways to obviate this problem, short of obviously going out and donating more blood. The second part of the question is, in the adult side, we keep 2 units of universal donor blood in a cooler in the trauma room. That has not been taken away from us yet. And I would like to know if such a thing is available in the pediatric realms in the centers that are collaborating with you. And thank you for an excellent talk.
Yeah, thank you. Great question. So yes, we are similarly dealing with the blood shortage. I was at the East meeting this past week, and it seems like that is a universal struggle for everybody right now. I was talking with our transfusion medicine chair a few weeks ago, and yes, we also have a shortage. And it seems that every transfusion is being scrutinized. Certainly is in the OR by our anesthesia colleagues. One of, they've highlighted kind of two ways that we should, that we can work on this. One of which is just being very selective with who we transfuse, which is really hard in injured children because you don't know who needs a transfusion almost. So there's probably some children that are getting it that don't need it. And then there's probably some that are getting it too late. And we just don't know who those are. And that's the goal of all of the scoring indices and things like that, because we just don't know. And I think until we do that, we're not going to be able to use blood most efficiently. The other thing is the whole blood program. Everybody is being encouraged to donate whole blood that works at the institution, and we're being used to transfuse it because theoretically it's a replenishable resource by our own staff, which is why it was used in the military with such success, because it was also an austere environment where component therapy was really hard to have and maintain a supply of. So whole blood was the solution of that, and ended up actually having some benefits. So that's the other part of it. And I don't know how much awareness there is of whole blood at an institutional level if you're not intimately associated with trauma like we are. So I don't know if there's potentially room for institutions to highlight that practice and that opportunity for all of staff to contribute to that. And then the second question about keeping the uncross-matched blood, yes, we do. I think most pediatric centers do that. It does seem like for whatever reason, there's a little bit of a hesitancy amongst certain, it just seems to come up more. People seem very hesitant to give uncross-matched blood to a child. And I think to that, which I usually say, if they're in shock, they need it, and we just need to do it. But you also have to keep in mind then, a typical unit of blood might be 300 or 330 mLs. That you have to do weight-based for children, or you might end up giving them probably more than they need. Nobody has studied overtransfusion in children yet. This has been studied in adults, and patients who are overtransfused or end up with hemoglobins like in the normal or super normal range have mortality basically equivalent to those who are under transfused. So that would be the other thing to keep in mind. But we don't have the data for it yet.
Hi, this is EJ.
Fantastic. We have questions from Dr. Simpkins and then Dr. Caterson.
That was one of the best talks on this subject that I've heard in a very long time. Thank you very much. It's pretty clear that blood will give you an initial response better than superior to the other products. However, it's not clear that it improves mortality, survival. I think that's because we really aren't embracing the pathophysiology fully. One can look at shock as three components. One, the volume, which we think about a lot. Two, the overproduction of nitric oxide, which begins within 10 minutes after severe hemorrhage. And the third is reperfusion injury and the role of reactive oxygen species and peroxynitrite and other radicals. And if you were to design a product for a shock, it wouldn't be blood with complement that causes reperfusion injury and causes organ damage. And that may be why in the long run, it doesn't really improve survival clearly. There are a lot of other questions that are emerging. What's the role of the interstitium, inflammation in the interstitium? What's the role of the numerous gases that are produced in shock? And what's the role of parasympathetic stimulation and that release of acetylcholine? There's a lot more to it. I think we've gotten diverted into clotting when really there's another the role of many, many other factors hasn't been addressed. So I think we need a revolution, I think, in understanding the pathophysiology of shock.
Yeah, I completely agree. And I wonder if a lot of the things that you brought up are in part why patients who are over transfused or they undergo massive transfusion and they end up with hemoglobins of 14 or 15 in adults, they have survival the same as those with a hemoglobin of 5 or 6. And so there's blood. So one of my other hats in practice and in research is pediatric oncology. And it's not been studied much in kids, but in adult patients with cancer, transfusion is associated with worse cancer survival, even after everything else is adjusted for. So stage for stage, severity for severity, more blood products is worse. And so there are a lot more, and that has nothing to do with the volume thing. It probably has nothing to do with a coagulation thing. It's all the other stuff. So I think that's an excellent point. And, the other thing I will say is mortality in pediatric trauma, fortunately, is very rare and low. So when we go to study those outcomes, such as mortality, the numbers that you need to show a difference are even higher than what is in the adult population. But yet we have lower numbers of patients to begin with. And I think that's also part of why almost any study of one particular intervention or anything in pediatric trauma almost never shows a survival difference. That's the only other thought.
Great answer. Thank you very much.
This is EJ. I
Dr.
wanted a
Caterson.
suggestion about the study model for you, because they're so rare. Is I do a lot of cranial vaults, and it's a great 3-hour pounding of a resuscitation in which children often get over transfused. But and so that's just a suggestion. But my real question is, when I look at the pediatric colleagues that I have, a lot of them hate trauma. And in the end, I think pediatric surgery is going to have a come to Jesus moment where they have to actually create an acute care service line. And they haven't done it yet. They've been very resistant to it. But I think that, it's coming. It's either going to be forced on them or not. And I just would love your thoughts on it, because you just told us that you probably love oncology, and all of a sudden you have to do trauma research and run the trauma bay. So it's a dichotomy.
That could probably be a whole conference on its own. There's a lot of that talk at our national meeting. It's always very controversial. I have mixed feelings on it. I do love trauma. A lot of my mentors in residency were adult trauma surgeons. And that's how I got involved in it and got interested in it. And subsequently, I've seen a lot of almost similarities in what I learned in trauma and about resuscitation and about the potential ramifications of resuscitation and trauma led me to be interested in studying it in oncology patients as well. So it is, it is a treasured part of my practice and certainly research, but I agree, I do share some of the sentiments about practicing it in real time, because there's a lot of challenges, where we don't get a ton of severely injured patients. And then when you do, it's very dramatic. It's very challenging. We don't have great data. It's super sad when the outcomes aren't good. And so I can see why it wears on a lot of pediatric surgeons. The problem with the acute care surgery model is that is going to work really well in probably bigger cities, higher volume places, but so many children, as it stands right now, already don't or can't receive care at a specialized pediatric center, or it takes them hours to get there. And so if we try to centralize it even more, I worry that it's going to leave out, it's going to end up leaving out or potentially harming those children that just are not going to have access there. So it would take some sort of, really sophisticated regional or even national system then to make sure that we don't leave kind of certain children in the dust there. So that's my only concern about centralizing it too much. And then, you know, that's been brought up for a multitude of pediatric things because our volume just isn't that high. So should we have certain people treating trauma patients or esophageal atresia patients or whatever, just so that they can be most experienced? But then you're going to have, these are really challenging time for these families. And it's even more challenging when they are then, you know, 5 to 10 hours away from home and their support systems. And they have other kids at home and things like that. So, you know, that's the hesitancy. And then if somebody severely injured does show up to your ER and you're not one of those, you know, acute care surgeons or something like that, and they need immediate treatment, then you're really rusty and your system is rusty. So I think, you know, that's an excellent point and something that is coming up all the time now at our pediatric surgical meetings. And I think it's pretty polarized.
Well, maybe there needs to be more adult centers verified for pediatric level 1 or level 2 in pediatric trauma too. Maybe, you know, to get that, there's certain components that you have to have, but they're not unreachable. And maybe they need to have more institutions address the problem rather than shunting individuals into that. Maybe that'll help.
Yeah, that's what I always have liked about the trauma community in general. It seems very much that everybody wants to enable, sort of enable more hospitals rather than, at least when I look at like a regional trauma center and stuff like that, it's not all about like, okay, send all the patients to us. It's, you know, how can we enable you to take care of what you're capable of taking care of, and you know, how can we help you with that, recognizing that if certain criteria are met, then absolutely we want them sent here, and we're going to help you figure out how to do that in the best way possible, which is what I've always admired about trauma.
Well, I think this is a really good introduction to us to some of the problems faced by the pediatric surgeons. And we hope to be hearing from you on a regular basis in the future.
Thank you.
We're
Thank you
going to
for having
shift
me.
gears. Oh, well, thank you very much. We're going to shift gears in a fairly substantial way right now. Steve Phillips has, for some reason, agreed to address us again. And he's going to be offering his thoughts in a more trauma-specific way than maybe he has in the past. And remember, this is a guy who's trying to give us the keys to the kingdom. He gets approached by people who are unsatisfied with their care, and a very small fraction of those end up going through the legal process. And he's trying to keep us safe. Thanks so much for coming again, Steve. It's good to see you.
Good morning, Jamie. Always nice to see you again, my friend. I'm going to try to screen share. My kids make fun of me, but watch this. Slideshow from the beginning. Everybody see that?
We can see and hear.
Oh, God bless. My name is Steve Phillips. I'm a plaintiff's lawyer in Chicago. I have been a lawyer for 38 years. Some of you guys will remember me from the last 2 years on the talk that you guys invited me to give. For 38 years, I have represented injured people. And for 38 years, I've done a fair amount of medical malpractice. On the plaintiff's side, I sue doctors. Ironically, I've represented a fair number of doctors as plaintiffs when they're injured due to medical malpractice. I've also represented a fair number of insurance company representatives when their family members are injured by malpractice. I come to you and I come to you with experience of 38 years of seeing what goes on. So I think I've got a pretty good background on what's going on in the legal system, and specifically what's going on with medical malpractice and trauma. And I bring you actually good news. For those of you who haven't heard my talk before, you probably anticipate that I'm the boogeyman. I'm not. In fact, I'm the opposite. I'm going to bring you good news. Let me see if I can reduce this so I can see this slide. Civil lawsuits are dropping significantly across the country. And this is something you probably never hear or rarely hear. Medical malpractice cases represent a tiny percentage of civil caseloads in 2019. That's the most recent data. And you see how statistically minimal malpractice cases are. That continues to this day. I'm almost certain, because I can tell you that cases still continue to drop significantly since 2019. We aren't filing cases, and we particularly aren't filing medical malpractice cases for multiple reasons, one of which they're very, very expensive. If I have a case, one-on-one, one plaintiff versus one defendant, minimum I'm going to spend out of my pocket is $150,000. That's minimum. So there's fewer plaintiffs' lawyers taking these cases, and there's fewer lawyers who are willing to take the risk once they review a case and filing a lawsuit. A case has to be significant injuries, death, or permanent injury for the most part before a plaintiff's lawyer is going to take that case. Tort cases consist of roughly 5% of incoming state civil court caseloads for the past 8 years. Isn't that fascinating? If you listen to the news, you listen to the media, and you listen to hospital administrators, it's an epidemic of lawsuits, injury cases. 70% of all civil lawsuits are contract disputes, businesses suing other businesses, and businesses suing people for money. About 20% are domestic relations and family law. Only 5% are tort cases, injury or death cases. Pretty eye-opening. These are the statistics across the country with the most current data. And here's the key takeaway. Roughly 2% of physicians accounted for almost 40% of all paid medical malpractice claims. 90% of doctors, more than 90% of doctors who had at least 5 claims were still in practice. There's a big problem with regard to malpractice with recidivists. And what we've seen over the course of time is that a small percentage of doctors have just a ton of lawsuits against them. And it's not coincidence. I had one obstetrician who had 14 lawsuits against him. I had another physician who had 9. And so what happens is that until the hospitals, and the hospitals are getting better about this, they're weeding out the bad physicians. They're finally getting it, and they're saying, look, either you need to go back for continuing education, or you need to find another place to practice. And that's helping tremendously. These are the statistics for Illinois. And Illinois is thought around the country as to being a good place for plaintiffs and a bad place for defendants, if you buy into the insurance mantra. Because what the insurance companies have done is they've hired a lot of lobbyists to go out and create the message on social media and otherwise that there are certain states in the country that are, they call them judicial hellholes. So these are the facts that we say, hey, wait, you can put any title or name on something you want, but you better have facts to support it. When I was the president of the Illinois Trial Lawyers Association, I went around the state and I showed the newspaper editors these statistics very similar to this slide, these slides. And it opened their eyes to the facts rather than the mantra. Illinois again. Number of malpractice cases filed in Illinois is down 37% since 2003. In Cook County, which is Chicago, which is thought to believe globally is a very favorable venue for plaintiffs, civil cases have dropped by 50% from 2010 to 2019. That's a pretty dramatic statistic. I think everybody would agree with that. You folks that are in private practice that are not in a, and have to fight the insurance companies and have to put in your claim forms to get paid. This is something that everybody should be aware of. And by the way, I feel badly for you guys, the ones particularly in private practice having to fight to get paid. I have a lot of friends who are in private practice still who have not gotten into big groups, and they're a dying breed because they just can't take the administrative time and costs of trying to get paid. This is what's going on with the healthcare companies. And this is one side of the spectrum, or one source of the squeeze onto the doctors, and one source of the squeeze on the hospitals. I get it. You folks in university settings, and many, not all, are getting the administration after you to cut down on unnecessary tests and to cut down on certain things. And a close friend of mine, very close friend of mine, is the head claims adjuster for the largest malpractice insurer in Illinois. And he said to me, he said, look, at this point, medicine in many ways has become almost the hospitals controlling, in many respects, what my doctors are doing. So this is in many ways a joint venture, and it's nuts, but this is the nature of the beast that my doctors have to deal with these days. So I think that's enlightening, and that's where some of the heat comes down from administration onto you guys. These are insurance companies. Liberty does reinsurance and malpractice. These other companies do not. But the reason I show this to you is because when they talk about Illinois being a really bad place for defendants, these companies, State Farm and Allstate, have their headquarters in Illinois. If Illinois is such a terrible place and so litigious, why do these huge insurance companies, who are much smarter than you and I, call Illinois their home? This is different. This is a new concept that I wanted to show you folks, specifically related to trauma. This is the cause of lawsuits in a trauma setting. Now, before we dissect this a bit, I wanted to tell you that I've been doing this for 38 years. I was the president of the Illinois Trial Lawyers, as I said before. I was the chairperson for the Medical Negligence Committee of the Illinois Trial Lawyers Association for 7 years. I do about 50% of my practice year over year is medical malpractice. You know how many trauma cases I filed in 38 years? 0. Not a one. And as a plaintiff's lawyer, one of the things I have to do is deal with the reality of what you guys do and the reality of how a jury is going to perceive it. You guys save lives. I applaud you for that. I respect you for that. And the jury's going to feel the same way. They're going to think to themselves, look, somebody came in from a terrible auto accident or a ski incident or something. And this guy got out of bed, came into the hospital in the middle of the night to take care of that person. And you're handed, for lack of a better term, a shit show. And I know in your mind, that's what you're trained to do. That's what your mentors taught you to do. In the mind of me, Steve Phillips, I'm going, hey, you know what? You guys are heroes. And the jury's going to perceive you as heroes. And I'm not going to try to prove that you should have set something a half inch closer than you did, that you should have fixated something an inch closer than you did. I'm not going to be able to prove that. So that's why the number of trauma cases is quite candidly so low. As I'm sitting here, I can remember one trauma case in Illinois in my 38 years. And that was when somebody was in a motorcycle accident. They didn't put a cervical collar on their neck, and it turned out they had a hangman's fracture. I ended up being a paraplegic or quad, I don't remember which. And incidentally, the defendant doctor was a recidivist. He had 7 or 8 cases against him. So it's multifactorial, but the big thing is, and this next slide will show you that the number of trauma lawsuits is very, very low. 45% of the trauma cases that get filed, and this is national, inappropriate management, mistreatment, failure to apply fixation. The next biggest one is misdiagnosis, delay, failure to diagnose. And then everything drops significantly. This is from an article published in 2021. So this data is very current. This is another table from that same article, the sources at the bottom. And what you'll see is that the categories for causes of litigation are separated between orthopedic and trauma. And you can dissect this data any way you want, but it seems to be the overwhelming likelihood that it's related to A1 and A2. Every one of my doctor friends, until I enlighten them, believes that every time there is a bad outcome, there is a risk of litigation. There isn't. Of the bad outcomes, I think the takeaway that you guys should remember is the second to last sentence. As few as 2 to 3% of patients with a bad outcome pursue litigation. And the conclusion of this paper from Johns Hopkins is the vast majority of patient harms never result in a lawsuit. I have a number of people who call me once they get to know me a little bit, who may have been a treating physician in another case, and call me and want to talk to me about something that happened in a hospital. And 9 times out of 10, there's going to be no litigation. It's small, it's nothing. Picture someone running a stop sign and bumping into somebody at a half a mile an hour and somebody walking away. That type of incident in a medical setting, it's not going to result in litigation. Even if you hear the patient say something about lawyer or lawsuit, it's not going to happen. No lawyer worth his salt is going to take that case. Here's another part of the Johns Hopkins paper. 1% of adverse events due to medical negligence results in a claim. I hope you're all relieved, and I hope this is eye-opening to you that you can go about practicing medicine, saving lives and taking care of patients without that gray umbrella hanging over your head. Victor Schwartz, the general counsel for the American Tort Reform Association, testified, "It is rare or unusual for a plaintiff lawyer to bring a frivolous malpractice suit because they are too expensive to bring." True. We have our share of goofballs on the plaintiff side, and there's a share of goofballs on the defense side. Sometimes a younger or inexperienced plaintiff's lawyer may file a claim based on a small owie, so to speak, or a really minor injury, or he thinks or she thinks they're going to get paid because there is some injury. Well, they learn very quickly that's not going to happen. So those are weeded out fairly quickly. This specifically related to trauma. The risk of malpractice lawsuit in the trauma setting is low. Now there's perceptions and there's reality. Well, this is the reality. Now, this is come from a paper in 2005. Some of you might say, hey, Phillips, that's 15 years old, 16 years old. And I say, yeah, you're right, but you can extrapolate pretty quickly when you combine this with the fact that lawsuits are dropping by almost anywhere from 37 to 50% in the civil setting and a malpractice setting. So this is probably more true today than it was in 2005. This was another conclusion of that paper. This is the key part of any malpractice lawsuit. A suit is not going to be filed almost universally unless death or permanent disability or injury happens. Very few people are going to file a lawsuit for a temporary injury. So combined with the fact that you see an event or you are witness to an event or you're involved in an event where there is a minor injury or minor mishap, don't lose sleep over it. It's probably the overwhelming likelihood it's not going to end up in a claim. Now, this is the enlightened. Some people might even call it the getting rid of the longest urban myth in my lifetime. You've all heard the McDonald's coffee cup. And I share this with you as something I do all the time when I give this talk. I'm a big Toby Keith fan. Toby Keith has a song that says, spill a cup of coffee, get $1 million. This is the facts of the McDonald's coffee cup lawsuit. On the right is 78-year-old Stella Liebeck. Those are her burns from the cup of coffee. She was not driving a car, and the car was parked at the time. The lid on the coffee cup had not been put on properly by the person who handed her the coffee at the drive-through window. She was a passenger. She was with her grandson. They pulled over, and when she went to remove the top, it wasn't secured properly. These are the burns she sustained, third-degree burns and to her genitals and her legs when the cup collapsed. She required multiple surgeries and skin grafts to address her burns. Records from McDonald's showed more than 700 people, including women, children, and elderly citizens, had been burned by the scalding coffee over 10 years. That's because McDonald's kept their coffee at 180 to 190 degrees. And her burn surgeon testified it takes 5 to 7 seconds of contact with the skin to cause these types of burns, rather than a full minute when coffee is kept, or fluids are kept at 135 to 140 degrees, the industry standard. Now, why did McDonald's keep their coffee so hot, you ask? It's about the money. It stays fresher longer. The jury awarded Mrs. Liebeck $200,000 in compensatory damages and $2.7 million in punitive damages for the conduct of McDonald's, about 2 days of profit from McDonald's coffee sales. That verdict was reduced on appeal. Mrs. Liebeck ended up with about $160,000, $180,000, and the punitive damage award was cut as well. So let me see if I can escape here. So let me see if I can stop screen sharing too. The message that I give to you folks is, number one, one thing I noticed in these 3 meetings I've had with you folks is you guys all speak really quickly. And I don't know if it's because it started in your residencies or it started in your fellowships where everybody speaks very quickly. If you want to make sure that something on one of your patients is well taken care of and carefully watched, make sure your younger residents and your fellows understand your message. It's very, very important. Slow down, make it clear. I have to tell my young lawyers, I have to slow down because I know all this stuff after all these years, right? To me, it's a no-brainer. Slow down, communicate to your residents so there's no mishaps. Number 2, do not be afraid to get a consult on one of your cases. There is no prize at the end of the year for who has the fewest consults. Get a colleague. I do it all the time. I've seen a lot, but if I have a new issue or kind of a wild card coming at me, I call some of my friends and ask them, what are your thoughts? And note it in the chart. I discussed this with Dr. So-and-so, we discussed this and this is what happened. Third and final thing is, if you do have a mishap with one of your patients, be kind, be nice. Do not become adversarial with them. A patient who likes you, much less likely to pursue litigation. A patient who thinks you're a son of a gun, kind of giving your patient the will to come after you, right? One final thing, and then I'll take a couple questions if there's time. Last year, I told you guys about a case I had where a man came in for an elective hernia procedure into the hospital, outpatient, 48 years old. Blood pressure is 209/142. They proceeded with the case. Yeah. Eye-opening, isn't it? And you can imagine what happened. He had a cardiac arrest, terribly brain damaged, and died 3 months later. The surgeon, general surgeon, I took his deposition recently, and he's also the assistant director of trauma at the hospital. I kid you not, testified as follows. When my guy's blood pressure in his office was 178/120, I asked him, is that an abnormal blood pressure? I don't know. What are the normal ranges of blood pressure? I don't know, not my responsibility. I depend on my medical colleagues. Is a diastolic blood pressure above 110 abnormal? I don't know those things. How about a diastolic above 120? I don't know those things. I asked him 20 different ways about blood pressure. He finally said, I know nothing about blood pressure beyond the things that a layman would know. So I tell you that because I see the proverbial shit shows often, and in a trauma setting. Now that's an outlier. I've handled half a dozen anesthesia cases over the years. What happened in the operating room was also unbelievable. Once he got in the operating room, they put him to sleep. His blood pressure dropped. They gave him some Labetalol before surgery. His blood pressure dropped to 50/32 before the surgery started. And I asked the surgeon, did anybody tell you that the blood pressure was extremely low? No. Would you have started the surgery had you known that blood pressure? Absolutely not. And it goes on and on. So anecdotally, I share that story with you about some of the really odd things that we see and things that really open our eyes. I'm probably a few minutes over my time. If there's time for questions, I'm happy to answer. If not, you guys can email or call me. I'm always available.
Dr. Kelly has a question, I believe. And remember, folks, Mr. Phillips is not on the clock.
Stephen, I enjoyed your talk and always find something interesting to see about it. One thing that I've noted in here in Massachusetts is that there's never a single defendant in a medical malpractice case. The number of defendants is always 10, 20. Some of that is the way that the lawsuits are structured around here. But as a member of the plaintiff's bar, do you find it more or less successful with a large number of defendants in terms of the likely outcomes for the plaintiffs?
I do not like, and all of my colleagues who do this regularly, we don't want a bunch of defendants. I think that's a bad idea, what you're seeing or hearing there, for multiple reasons. One, as a plaintiff's lawyer, you're going, wait a minute, I have to prove that 15 different people screwed up? That's a tough hill to climb. Number two, I don't want to deal with 15 different doctors. Number three, I don't want to deal with a bunch of different defense attorneys. If you're smart as a plaintiff's lawyer, you will get down to the absolute most basic theory or problem of malpractice and pursue that. Sometimes at the beginning of a case, there will be a lot of people involved, and that's out of an abundance of paranoia, because I can't tell you how many times after the statute of limitations is run, when I'm questioning the target defendant who clearly screwed up, he will say, well, it wasn't just me who made that decision. It was Dr. Jones, who I consulted with, and he's not in the chart. So there are twists and turns to that. We have in Illinois, and I suspect most advanced states have, something called a respondent discovery, where at the beginning of the case, we sue just one defendant, like the hospital, and we name 5 or 10 different people who are respondents in discovery. Those are people with knowledge. They're not defendants. And we can get their depositions very quickly and find out that they aren't involved or they are involved. And it's a wonderful way to get rid of people who don't belong in a case, get them out of the case very quickly, and streamline the rest of your case. And it works very well. And if they don't have that in Massachusetts, I would suggest that you talk to your hospital people, because they should get their lobbyists to lobby the legislature to set something up like that.
I don't think they have much enthusiasm for that. In the state of Massachusetts, decisions and awards have been capped against institutions for many years. And the last I looked at it, the cap was about $20,000. So they're more or less invulnerable. It's the companies that provide malpractice insurance that are the main players in terms of trying to get the reforms carried out. So I think that is probably a good place to start.
Yeah, yeah, it really works well. It's been a good thing in Illinois.
Yeah,
Thank
the
you.
Mass Hospital Association has it all figured out. It's all the docs. Do we have other questions? This is a great time to talk with someone on the other side of the fence.
I have a
without
question.
being at risk. Yes, Dr. Simpkins.
If, excellent talk. Some states have panels of physicians that review malpractice cases. Do you think that's a useful step or not? I don't know if suits go on regardless of what the panel decides or not. But do you, in your experience, is that a useful mechanism?
Our neighboring state, Indiana, has those panels, and I have filed a few cases there. Is it useful? It's useful for defendants for sure. It's not fair from a plaintiff's side, because what we have found with all of these panels is, with rare exception, and we perceive it as a rigged plumbers union election. Because typically in I hear somebody's alarm going. In Indiana,
It's my wife's. I'm sorry.
Quart of milk, loaf of bread. In Indiana, the plaintiff picks a panel member, the defense picks a panel member, and they pick a third doctor. And what happens is that 9 times out of 10, the plaintiff loses for a variety of reasons, but we can then file the lawsuit. The panel doesn't control, but in certain states, the panel findings come before the jury. I'm not that worried about the panel findings coming before the jury, but what it does is it adds an extra layer of cost to the thing. What we do in Illinois is, and I think most states do this or should do this, is we have to have our cases reviewed by a physician who then has to sign a report identifying that there is a meritorious basis for the lawsuit.
Have you ever sent it to a physician and gotten a different answer when you're paying for it?
I'm sorry, can you say it again?
Have you ever gotten a different answer from a physician when you're paying for the merit? In other words, you really want to know what they think, or are you paying for a doctor to say, yeah, there's merit in it?
Oh, no. I want to know whether it is a real case. And any plaintiff's lawyer worth their salt wants to know if it's a real case. Doctor, don't tell me what you think I want to hear. I want to hear if this case has warts, because I'm going to handle this case for 5 years. And the minimum I'm going to spend on this case is $150,000. I don't want to lose. If there are problems or warts in this case, tell me from the get-go. In fact, I tell all the young lawyers when they come running in, I talked to Dr. Jones and he told me this is slam dunk. And I will tell them, bullshit. Go read the literature, find out how the defense is going to defend this, and find out and challenge our doctor. Because I would say half of the reviews that I get from doctors, I will then read the literature and figure out what's coming at me. And I'll call them up and say, hey, look, you told me A, but I've got these 3 papers that say A is malarkey. How would you respond to that? And I've told my senior partner and I have had these discussions. We say, well, we're not going with what he told us. I want to hear how the case is going to be defended. And I won't file the case, even though I have a doctor who told me that it's meritorious.
Yeah, Steve does know how PubMed works. Thanks for trying to protect us from ourselves and your colleagues on the bar. And right now it's time for Dr. Williams to give us his presidential address regarding lessons he's learned from General Powell. Now?
And I wanted to thank Jamie for all the hard work that he's done to make the society and this meeting successful. And I also want to thank the society for allowing me to make this presentation about someone pretty important to me and to the history of this nation. I want to talk for the next 25 minutes or so about General Colin Powell, and I want to present him in the context of being a leader supreme. I'll make my case. Next slide. I have no disclosures except that no financial disclosures, except I and most of the world are very biased on this matter that I will be presenting. Next slide. When you look at where this nation received such a miraculous leader, such a great man, he is from here. He was born in New York, but his parents immigrated. And his parents immigrated from Western Jamaica. And they immigrated at a time where it was difficult to some extent to immigrate, both in cost and to immigration structure. His mother, Ari McCoy, comes from Westmoreland Parish, and she was married, she was the daughter of pretty affluent individuals. And his father, Luther Theophilus Powell, comes from St. Elizabeth's Parish in Jamaica. Ari McCoy would arrive at Ellis Island, and Luther Powell would arrive in Philadelphia initially, and then make the trek to New York, where they would meet in Harlem and then the result of that union would be Colin Luther Powell. Next slide. Immigration, if you were a Negro or African, and it's important to understand that during that time, anyone who was of dark skin was labeled Negro or African based on U.S. immigration policy. So it didn't matter where you came from in the world. The policy was that if you had brown skin, you were labeled as Negro or African. And part of how you immigrated into this country was a literacy test. This was a law passed by Congress for the U.S. Bureau of Immigration. And that literacy test meant that you had to read this Bible passage. He hath also prepared for him the instruments of death. He ordaineth his arrows against the persecutors. Behold, he travaileth with iniquity and hath conceived mischief and brought forth falsehood. He made a pit and digged it and fallen into the ditch which he made. Psalm 7. You had to be able to read that. In 1927, according to U.S. Bureau of Immigration Statistics, 98.7% of all those labeled African could in fact read this Bible passage. And I would take this Bible passage now to most American colleges and we wouldn't get numbers that high. It's a pretty hard passage to get through in order to receive immigration status. Everybody had to read it. This was not something peculiar to you being of a certain race, by the way. Everybody had to read it. Next slide. So Colin grows up in New York and he goes to Morris High School in the Bronx. Now, his parents, Ari and Luther, have pretty high academic hopes for him. That's a very rich West Indian community or Jamaican community that they bond with here in the US. And they kind of begin to think of Colin as an individual who's going to be this outstanding young man. The fact of the matter is that his sister, Madeline, was really the brains of the operation. She was the one gifted academically. Colin was basically just an average student. Next slide. He would do well enough to go to City College of New York. And look at the mission of City College of New York. It says to provide children with poor and new immigrants the higher education that could give them access to the American dream. This was their mission. And what a mission did they fulfill when it came to Colin Powell. He would go there, he would start a major in engineering. That would not last for long, which makes him similar to most engineering majors who are freshmen in college. He would change his major to geology. How many people knew that Colin Powell graduated with a degree in geology? Certainly that was not something that I knew about him and I take great interest in him. But he would go to this local kind of community, kind of oriented college that had these big dreams for these children. And this would be the basis of his education. Next slide. One of the things that would catch his attention early were the Pershing rifles. And many of you will know John J. Pershing. He was a lieutenant at one time at the University of Nebraska. He would go on to become a general, and he's actually one of two generals of the armies in history. But the Pershing Rifles is the oldest organization on a college campus that perform military drills. And Colin would see them in their uniforms, twirling these rifles and doing these routines, and he became enamored. This is the bait that draws our dear Colin Powell into the United States Army. And so he would join the Pershing Rifles at City College of New York. And not only would he join them back in the 50s, but he also would be there in the picture all the way to your left on the screen of him as an older gentleman. He would be there for the reinstallation of that chapter back at City College of New York. Next slide. Now, mentorship became important in Colin's life as it is in all of our lives. And the command he would nominate him to be a distinguished, which would allow you to get a regular military commission and not have to go for a reserve commission after away time at West Point, that great citadel by the Hudson. And he would go up there with Colonel Brookhart's son, and he would begin to understand military life. The roommate of Colonel Brookhart, who was also a graduate of West Point, was the great Benjamin O. Davis of Red Tail fame, the nation's first Black Army general. And when he was at West Point, he ate alone, he slept alone, and had many engagements that tried to make him quit, and he persevered and got through. But these stories Brookhart shares with Colin that kind of began to instill in him the perseverance that's going to be necessary to be effective and to be successful in the Army in the 1950s. Next slide. And so he finishes CCNY with his degree in geology in 1959. And where do you head when you go into the Army? You go to the home of the infantry, Fort Benning. Okay, that's where you start your career as a little second lieutenant in the United States Army Commission. We have another second lieutenant around here helping us with the AV. He would go on to put on the Ranger tab and the Airborne tab before leaving Fort Benning. No small accomplishments, no little achievements. He would do both of those things, and he would finish near the top of his class. And so the star is beginning to develop at a very young age, and it's clear that a bright, promising future may be available for Colin Powell. What you need to know is that his mother, Ari, and his father, Luther, do not want him to pursue an Army career. His mother says to him when he leaves for Fort Benning, do your 3 years and get out and come home. And what Colin Powell is doing is kind of shaking his head up and down at his parents, but really deeply inside of service for this nation and for the military, to the point where he understands that this is going to be a lifer or a lifelong journey. Next slide, Jamie. Go back one. There we go. This is wonderful. So his first deployment in the military is in Frankfurt, Germany. And he's actually seated at the Vogelsberg Mountains near the Hessian Corridor. And you may say, well, what is the Hessian Corridor? The Hessian Corridor is the natural route in which European invasions took place. And this is the time in our nation during the Cold War where our policy is an overwhelming response to any attack against America or its allies. And he is here guarding this passage. On the other side of this passage, there are 6,000 Soviet tanks and 5 divisions. Clearly outnumbered, but nevertheless, he's there. That's his first deployment. And what he takes away from this beautiful, picturesque place in Germany is an interaction he has with a captain there who is his superior officer, who teaches him one major thing. Officers in the military are not political entities. We don't function in political ways. And in fact, so much so that many officers, high-ranking officers in the military, do not vote. This is something that you will hear echoed by General David Petraeus years later, a person who also would tell you the same thing. That is what he takes away from this first deployment. But he is clearly, as a training and operations officer, beginning to gather great recommendations and evaluations at a very early age. Next slide, please. This is so very important. And it gets at a lot of the love for General Colin Powell. He is sitting and resting upon a history of service in this country by a community of individuals. It is, in fact, Executive Order 9981 by Harry Truman, which integrates the armed forces, creates what we think of as a leveled playing field. And when we look at previous wars, and we can go back to every war, including Crispus Attucks and the Revolutionary War, but the ones that we have documented data for, we can see that there were significant challenges for African Americans who served. in the African-American community, service in the military was the way in which we demonstrated our great patriotism for this country, despite the status of our citizenship. So even when the right for enfranchisement was not bestowed upon us, we served this country and we served it faithfully under some pretty significant challenges. And even after Harry Truman desegregates the military in 1948, it wouldn't be to 1954, exactly 5 years before Colin Powell would arrive in Frankfurt, Germany, that the last engineering unit in Europe desegregates. So this was a with all due speed type of situation. So even after an executive order by the commander-in-chief, we went for 6 more years as a segregated army in some part or fashion. And the challenges that I have mentioned on the chart you see on the slide, they are in front of or in addition to the fact that African Americans were not being honored for our service. We were not receiving the medals. We did not receive medals of honors, and we had unequal retirement benefits. Next slide, please. He would go on to Fort Devens in the Northwest. All of my Massachusetts members will know Fort Devens. And he will make the best decision, leadership decision in his life. He would marry Alma Johnson, who would become Alma Powell. She is an aristocratic young lady from Birmingham, Alabama, and her parents are principals, okay? And so this is how Colin Powell, as a Jamaican immigrant, becomes aware of the American South at this time during the 60s for days, because he's married to Alma, and they go down and in fact they get married in Birmingham, and this makes him aware of the issues of civil rights and these types of things. And I like it the way Alma put it when they are dating and it's coming up and it's time for him to go to Vietnam after Devens, Massachusetts, and he's negotiating this relationship as a good Army officer knows how to do. And he says to her, well, we're going to keep in contact with one another. And Alma Johnson looks back at him like a superior officer and says, oh, no, we're not. I'm too old to be a pen pal. And at that point in time, like all good Army officers know, that's the moment of decision. You either hold them or you fold them. And so Colin Powell at this time goes back to Devens, Massachusetts, and he sleeps in his bed and wakes up and said, wait a minute, Alma is kind. She's thoughtful, she's smart and beautiful. She's a good cook and a great dancer. And he goes back to Devens, Massachusetts, and he sees Alma and he says, here's what we're gonna do. In 2 weeks, I'm gonna marry you. And that is the story of how Alma Johnson and Colin Powell become married. Alma Johnson is great in her own right. She's working at Emerson College in Boston at the Institute for the Hard of Hearing. And so she is already contributing to this nation in a great way, serving handicapped individuals. Next slide. No problem. He goes to Vietnam. There's no more of a defining war in the history of this country than Vietnam. I see it every day in my life, in the decisions that my bosses make, in the decisions that senators make, in the decisions that presidents make, in the decisions that older individuals who are still wearing that harness of this war, who've never kind of broke free of this war, can't quite shake loose. It is the defining challenge of this nation's history. And what Colin Powell sees is a futile attempt of American interests to fight off what we believe is expansion of communism. First of all, let me correct history a little bit. Ho Chi Minh was no great lover of communism. Ho Chi Minh, by the way, is one of the greatest leaders that ever fought against this nation. Ho Chi Minh hated French imperialism. He wanted the French foot off of his people's neck. And so he chose communism as a tool to do that. He was not a rabid communism in any sense of the way. But what he was, and military men know this and we respect it, we do not have to like you, but we will respect you if you are a great, great enemy and foe. And that's what he was. And he made the statement we shall not count the costs when fighting the United States with regards to the independence of Vietnam. We did count the costs, literally. And I think Secretary McNamara was one of the great counters of that cost, and he's certainly no stranger to this organization. What Colin Powell said when asked about Vietnam before leaving one time, he said, it'll take 500,000 men to even begin to approach what we're trying to do. And for those of you who lived during that time, you know that we trickled men into Vietnam little by little by little by little, and we bombed and bombed and bombed and trickled men in little by little by little, and it never, ever worked. But what Colin Powell would do here for his own career is probably greater than what anyone could have done for a poorly strategized war. He was assigned to the 2nd Battalion and 3rd Infantry Regiment as an advisor, as all of them were at that time. And as a young major, he became an XO of a division. He received early promotion to Lieutenant Colonel, received a Bronze Star and a Purple Heart for being injured in Vietnam. He actually rescued a commanding officer from a helicopter wreck in which he was already injured. And these were his heroic bona fides in a very famous war tale. Next slide, please. What we all must know and reconcile and deal with when it comes to my dear general is that those who fought in Vietnam felt betrayed, a deep level of betrayal. This was not trivial. There were no parades. They were called murderers when they came back to this nation. And they felt that the betrayal was from a government that didn't have a good strategy and didn't really have the commitment of the American people, nor was there a clear objective. And it is this deep feeling of betrayal that would shape their doctrines and how they would govern and how they would lead going forward. There was no interest for frivolous war. You had to have commitment by the American people so we could put the right number of men on the grounds, we could clearly have a clear objective, we could win and we could get out. That shaped their leadership styles. If you don't understand Vietnam and what happened there, you can never understand the decision processes of General Powell going forward. You must first reconcile and deal with the failures of Vietnam. Next slide, please. 58,000 casualties. We've heard about the architecture of that great Vietnam memorial that sits on our National Mall. I really recommend that all people go to it. But the weight of 58,000 Americans rest in Vietnam, along with a mistrust for the government and its decisions. Next slide. When he comes back from Vietnam, he's already arranged to get more education. The 3 institutions that would kind of shape that education would be George Washington University, where he would get an MBA. He would do a White House fellowship in the Nixon administration, which would become key because it is there where he would begin to meet the people who he would kind of what we call his DC group that he would end his career with. And that is Frank Carlucci, and Secretary Weinberger. At that time, he wouldn't be Secretary of Defense. He was Nixon Director of Office of Management and Budget. And he would also go to the prestigious National War College and learn the higher techniques of diplomacy and foreign policy. Next slide, please. When you look at General Powell's ascension through the military, it is literally better than an Amtrak station. The trains ran on time in his career. Every 3 to 4 years, a star fell on this man's shoulder. So 1979, he's Brigadier General. In 1983, he becomes Major General. In 86, he becomes Lieutenant General. And in April 4th, 1989, he becomes General. If you want to know the ascension, it's Be My Little General, if you want to remember it. And it's so miraculous how he was promoted successively through the ranks that it is a story in and of itself. Next slide, please. The height of his fame in this country and his leadership is the Gulf War, or the Persian Gulf War I, or a Desert Storm, whatever name you want to call it. But you're talking about a 35-nation coalition, just short of 500,000 men. 2 of the biggest tank battles in American history fought, and a liberated country and Iraq, driven back out of Kuwait to everyone's great joy. With that success also came questioning of the decision making not to go all the way to Iraq at that time. And later on in his career, you would see the criticism of neoconservatives who would say we should have just the first time just went all the way to Baghdad. Again, you can't understand the decision making of the general. He's at this point in time, he's Joint Chiefs. He's chairman of the Joint Chiefs of Staff. You won't understand the decision making there if you don't understand Vietnam. And what you're going to see in these later slides and in his later parts of his career are two factions developing. Those who have fought and bled for this country and have a perspective, those who have not and have a perspective. You must be the final judge on where you think the truth lies. Next slide. His government service is extraordinary. I've outlined it here, but he essentially goes from being a senior military assistant to President Reagan. He goes over to the Defense Department as well with Cap Weinberger and is a senior military assistant. He is Deputy National Security Advisor under Frank Colucci. He becomes the National Security Advisor under President Reagan, and then he goes on to be Chairman of the Joint Chiefs of Staff, and then finally Secretary of State under the son of Bush. Next slide. When you look at the Powell Doctrine, as it is outlined, where does that Powell Doctrine really come from? It really comes from his time with Caspar Weinberger. Caspar Weinberger is a person who put forth his own doctrine. He said, listen, there has to be a way in which we agree upon entering into a military conflict or use of force. He says it's got to be overwhelming force when we decide to use it. We're not going to be at war forever like we were in Vietnam. We're going in heavy, we're going to accomplish the objective, and we're going to get out. It has to be a direct threat to American interests. In other words, if what we're fighting for is not intrinsic to this country's interests, we're not going in and getting bogged down in any kind of war. You have that support by the American people. Defense has to be the last force has to be the last resort, and we have to have limited definable objectives. The Congress and the American people must understand the war. Next slide. When we look now, it's important when Weinberger's doctrine comes out, General Powell is working for him as his senior military assistant. And so he is helping writing that Weinberger doctrine out of his lens, out of his perspective from Vietnam. So when we see the Powell doctrine, Colin Powell does not name this the Powell doctrine, the media does. But you see the same themes running through the Powell doctrine in terms of use of force that you had running through Caspar Weinberger's doctrine. That is, you got to have a clear objective. What are we doing and why are we doing it? We got to have every other thing has failed, diplomacy and all of the nonviolent means. We have overwhelming force that can be used to complete the objective. And we've got to make some assessment about the risk benefits of this thing. And we have to know the consequences from the beginning. Next slide. When you look at Secretary of State Powell's service under George W. Bush in that administration, you have just simply a difference of opinions that has to be understood from the beginning. You have neoconservatives who believe in unilateralism. They believe in American exceptionalism. When you study carefully their history of service to the country, the history of service in government is extensive and should be applauded. The history of service in boots, carrying guns and weight in hot, humid areas is lacking. In fact, there are draft deferrals that can be found in their history. And so when you begin to understand the schism or the chasm that runs through the Bush administration, as it relates to military policy, as it relates to foreign policy, it is because there are two sets of life experiences that go behind those perspectives and points of views. Quite simply, Colin Powell is a multilateralist. His doctrine is clearly laid out in terms of his use of force. He's not go in, knock over the nation, get out, just because we can do it. Okay, there is another perspective on the other side that is a little bit more aggressive in terms of use of military force. Next slide. So let's talk about what everybody talks about when it comes to General Powell, which is the UN speech. And most people, when they talk about the UN speech, start at the UN speech as if he wrote it 5 minutes before going into the UN chambers and giving it to the General Assembly. The fact of the matter is that speech was in development for a little bit under a month. And they were in the office of the National Director of Intelligence. After the deputies would cull the data down, Secretary of State Powell would go to George Tenet, the head of the CIA's conference room, and they would deal with the highly sensitive intelligence information. This is what we call trimming the garbage, getting rid of the stuff that don't add up. What are the key pieces of evidence that we're going to take in terms of making the case to go to war in Iraq? And really, there were 4 pieces of information in that speech that were what we call the weight, the heaviness of the case. First was mobile biological weapons labs. In the prequel to the UN speech, in the National Director's office, in George Tenet's conference room, what was said was this: we got 4 different validated sources that we got mobile biological weapons laboratories that are moving across Iraq. This is totally reliable information. That is George Tenet's statement to Secretary Powell. When it comes to Captain Ibrahim, that piece of information was a communication intercept, which says that they heard Iraqi troops talking about biological agents. The statement particular that was intercepted was, take nerve agents out of the CEOI. That's your Communication Electronics Outcomes Initiative. So they took that statement and made it to mean that someone possessed nerve agents, and some of General Powell's or Secretary Powell's lieutenant said, wait a minute, maybe they're taking it out because they don't have it and there's no need to talk about it. But it was heavily contested. It remained in the speech. And finally, I think what we all remember, next to last, what we all remember, this issue of aluminum tubes that were going to be used for centrifuges. Got really caught up in that and very dramatic. CIA's assessment was that this was clearly designed for nuclear enrichment. This was the data that was presented to Secretary of State Powell in the conference room of the Central Intelligence Agency Director. This information was proffered for by U.S. American intelligence.
Mallory?
Yes.
This is in the context of Saddam trying to prepare a nuclear weapon in the past and Saddam bombing Iranian troops with nerve agents.
That's correct.
So there was a history, so there was no reason to think this was wrong.
That's correct. The CIA proffered that these aluminum tubes were not for rockets, but for centrifuges. And finally, the association with Al-Qaeda, which the president and the vice president had mentioned, which was a private transcript from a captured bin Laden aide, which said that there clearly was an association. Specifically, they said that Al-Qaeda had gotten chemical and biological weapons from Saddam Hussein. All of these facts were discussed heavily before they were ever put in the speech, and the intelligence behind these facts were reviewed by the secretary, his team, and by the Department of Defense, and determined based upon that information that they were legitimate issues to go forward with. Next slide. So I ask you, if your wife comes and gives you a piece of information and swears by it, who doesn't believe that? As a colonel in the United States Army, if my nation tells me, gives me intelligence that tells me that these things are true and backs that intelligence up, there's no reason for me not to believe my nation. And so that was what went forward on February 5th, 2003. The facts that have been heavily trimmed and looked at very carefully were presented before the nation as facts in a cause to go to war. Each of these facts, it turns out, subsequently was wrong. Not only was it wrong by a little, it was wrong by a lot. And when we look at the sources of those facts, which was never presented to the Secretary of State, but was known by the Director of Intelligence, the CIA, excuse me, the Director of CIA, that this was a lot of Shalal Abi's people who wanted him back in power in Iraq, proffering information, giving us whatever we wanted to hear in order to change the regime. It would become the single most embarrassing moment of General Powell's career that he would regret and apologize for. Next slide. What responses to this speech? The Washington Post said the evidence is irrefutable. The New York Times says it's the most powerful case presented to date. This was the media praising this speech rather than interrogating it or doing more investigative reporting on it. And finally, my friends from the Jerusalem Post said in the most provocative way, scratch everything we've said about Secretary of State Colin Powell. We love him. Next slide. When we look at the totality of the accomplishments of Secretary of State Powell, it goes beyond the speech that he gave on February 5th, 2003. He rebuilt the confidence within the State Department amongst senior foreign service officials, successfully adjudicated the dispute of the F-18 collision with the reconnaissance plane, which was kind of messy, built a coalition against al-Qaeda while managing the Palestinian we can never forget that Simon he was performing shuttle diplomacy for. Some will call it effective, others will call it very ineffective. Whatever name you want to put on the intervention is beside it. He was doing two things simultaneously, which both of these things were in conflict with one another. Another success. And of course, the African assist for the AIDS virus, a whole view of what his accomplishments were as Secretary of State under some very challenging situations in an administration with the most powerful vice president that we have ever had in the history of this country. Next slide. You know you've done something right if at the end you've got 4 presidents sitting on a pew, well, 3 presidents and a Secretary of State sitting on the pew of your funeral, and they put you in Arlington National Cemetery. What is most remarkable to me, colleagues, as I bring this presentation to a close, is that if you look at the tombstone that marks General Powell's grave, it is similar to every other soldier's tombstone that sits in Arlington Memorial Cemetery. And the epitaph simply reads General U.S. Army. And what does he put underneath of that? Vietnam, the Persian Gulf. Nothing about being Secretary of State, nothing about many other accomplishments, but just the things that were service-oriented to this nation appears on his headstone. Next slide. But I think this is what we will remember. We will remember him for most. And that was the impact that he had on the troops and our belief in him as a leader. Something that we also had, by the way, with David Petraeus when I was in the Gulf as well. I think that's his legacy. I think that's one of his great lasting legacies. And for me as an officer in the United States Army, there's never a time that I put on my uniform and didn't think of him. Thank you.
Great history, particularly in light of some of the discussions about how to work better and what constitutes leadership. Do we have any questions?
Yeah, I have one.
Dr.
Mallory,
Simpkins, then Dr. Bayme.
Mallory, that was fantastic. One of my earliest memories in life is when my father was in the Air Force and I was walking with him. I was about this at this, my height was about where his pistol was. And I saw it come out and he arrested the soldier for not saluting him. This was an enlisted person who wouldn't salute a lieutenant. And I remember my father arresting him. And then the other thing I remember, this is just to talk about the kind of stuff, I don't think people imagine the kind of things that he went through. But the other thing I remember, they wouldn't give us housing either. And my father went to see President Truman and got us housing. The third thing I remember, there are many things I remember, but just to be selective, I remember he had to order the barber to cut our hair. Now, having said that, I served in the military, in the Navy myself, and I'm very, very proud of my service. And I will say that as bad as that was, it was far ahead of where American society was at the time. And in my experience, being in the military in the 1980s, it is the closest thing to a meritocracy that we have in this society.
Yeah.
And I wish we had followed General Powell's principles in all the wars that we fought, the second war in Iraq. The other wars that we fought. I wish President Bush had taken his advice. That's big deal.
I think the story of veterans, particularly going back to World War I, but also World War II. And you look at how this nation chose to honor those who served it. It's despicable. We don't shrink away from the truth in America. We embrace it and we look it head on. And we have to correct that. I think you see presidents who are in the modern era posthumously beginning to correct that history in terms of the awarding of medals of honor and the appropriate medals that should have been handed out in World War II and World War I. Look, it's despicable because when you look at who took the majority of the casualties, whether it's the Civil War, going all the way to World War II, it was segregated units. This, the Department of Defense knows, this is a part of our history. It's part of our record. If you fought in the Civil War in a segregated unit and you got caught, you were not given quarters as a soldier. You were killed. And so it's good to see a career like General Powell's. He becomes aware of the history that we're talking about now, actually a little late in his career. He is the person who would commission the statue for the Buffalo Soldiers at Fort Leavenworth in Kentucky. He becomes more outspoken later in his career about the issue of the recognition. And when we say recognize, I understand as civilians, when I wear my Army Commendation Medal or Humanitarian Medal or whatever medal that I may have in my portfolio, that is you acknowledging me as one of the less than 1% of you that serve the interests of this democracy above my own, clearly above my own now that I'm a surgeon. And I'll, a few weeks from now, I'll be back in active duty service as well. I'll make $35,000 a month. So the issue of how this nation acknowledges soldiers is a fundamental bedrock in our democracy. It's not something that we play with or take lightly. At the end of the movie Gladiator, when she comes to the dirt of the Colosseum, she says he was a soldier of Rome. Honor him. And so we can't not be in perfect protocol as it relates to the people who defend this nation.
Thank you, Mallory. Michael Bayme has a question.
First of all, that was a great review of Colin Powell, as someone we all look up to.
No, thank you, brother. He was greatly admired in that country. I remember him getting off the helicopter and receiving full salutes by IDF members. It was a fantastic.
You glossed over one of the important parts of history here.
Oh, go for it.
Colin Powell belongs to everyone. So I imagine, some people want to claim him as Jamaican heritage,
Yeah,
and I'm sure people want to claim him as Afro-American, but I look at him as a New Yorker. In this
yeah.
day and age, no one from New York goes to the Army. The Army is the South. So all of a sudden you have someone from New York. And then, it's funny, I guess little bits of history apply to different groups, and it's unfortunate. But Colin Powell, from age 5 and up, was part of the Jewish community. Colin Powell was what's called a Shabbos goy. On the Jewish Sabbath, when the Jews can't turn on lights or turn on heating, his job was to come to the synagogue every Saturday morning, turn on the lights, turn on the heat. I mean, he got paid probably a nickel a week or something, some small amount, but he was part of the community. He also worked in the store on weekend, some toy store from a Russian Jewish immigrant who taught him to speak Yiddish. Colin Powell is famous for speaking Yiddish. And when various Israeli leaders met him, he would speak to them in Yiddish and knock the socks off of them. So I grew up knowing that Colin, and I know maybe to his credit, as far as I'm concerned, Colin Powell, it's a colorblind view. Colin Powell is this New Yorker, was part of the Jewish community for, an extended sense, who went on to be a great guy.
Yeah.
And I
Well,
think
so
it's
am I. But
and so I just,
he, from a religious standpoint, he's Episcopalian. He considered himself. I'm just telling you how he defined himself. I agree with the sentiment that he belongs to us all. I began the presentation by saying that everyone in the world is biased about Colin Powell. We love him, and he could go into many different locations and be well received, and did in fact. He called himself a Black man, even though he was of Jamaican origin. I don't mean to exclude by any measure or means him from any other communities, because quite frankly, brother, I hang in many different communities too, and am claimed by many different communities. And I love that. I love that sense of togetherness as well. But the fact of the matter is, when he was handled in the United States Army, in certain particular incidents that I didn't put in the presentation, someone saw him in a particular way when they were handling him in that way, and that's unfortunate. But I do love the story of this job.
No, it's Colin Powell is part of Jewish history in New York, as far as we're concerned. I attribute to him his success. Unfortunate what happened to him along the way. He was clearly someone who we all looked up to. And hopefully, as we move forward in life, we can go over, forget about differences and recognize people who are leading the country. So thank you once again for a great talk.
Thank you, brother, always.
Thanks, Michael. Do we have any
Mallory,
other
I think that one of the things that this shows is the absolute necessity of having everybody serve, and an army be everybody's army and not a professional army. Because one of the reasons why I think that the Army here was always a step ahead of the rest of society is that when men end up giving blood over a cause, there are bonds that are made, right? So the term brother comes from, I think, the military, brother in arms. Yeah. And I think that for me, on a personal note, what made me much more sensitive to people that come from different upbringings than I do was my service in the IDF. Because without it, I would have been, especially in Golani, which is sort of similar to, let's say, the Marines or some rougher unit here in the States, and I'm talking about the 1st Marine, not the 2nd or the 3rd, I'm talking about the real soldiers, the infantry. And at the end of the day, I think that our willingness to go to war or not go to war has a lot to do with, are the kids who are fighting the war from fly over America, or from some poor neighborhood in an unimportant part as perceived by the elites on the coast in the center of the country, or are they their kids as well? And so I think that this country is doing itself a disservice on multiple levels by not having by not having it be really truly a people's army. And
I'm in
having
full
everybody
agreement
share
with
the burden.
mandatory service.
Yeah, I agree with that too.
And then I got to
We've
tell you,
had
I've
it.
learned so much in my 18 or so years that has contributed so much to what I do in the day to day that I don't regret doing it. I don't regret spending the 6 years of active duty along the way, and then the 12 years of reserve duty and everything else. I think I personally gained an awful lot from that.
I agree 100%. Not an hour do I regret.
Thanks again to Mallory, not only for a couple of great talks, including one on the fly yesterday, and for helping us build the organization over this past year. We're quite lucky. We're coming to the end of the morning session. We'll be back again at 3 o'clock Mountain Time. And I have been closing off these meetings myself. If Dr. Belfar could stay on briefly, and the rest of you, I'll be seeing you this afternoon. Thank you very much. We've got a great show here. And you will notice that Dr. Cornwell, who will be speaking this afternoon, popped in to look at Mallory, and we'd all like to say hi to him. Thank you very much, all of you.